كلمتين بسرعة وخلاص.
اتفضلي حضرتك. اهلا وسهلا.
أهلا وسهلا.
الدكتوره نجمان المهندس، آه، رئيسه او مديره American Association for Continuous Medical Education. اهلا وسهلا بحضرتك. ويلكم حضرتك.
ويلكم.
شرف ان حضرتك تقدمني وفرصه
قدمني
سعيده.
وفرصة سعيدة.
اوكي.
اوكي.
السلام عليكم ورحمه
السلام
الله.
عليكم ورحمة الله.
دكتور
دكتور نجم
جنرال مانجر.
مانجر.
هو الصوت
هو
فيه
الصوت فيه معلش
في صدى.
في صدى.
هنلغي الصدى.
هنلغي الصدى.
شاهر كده تمام يا دكتور ابو بكر، كده تمام.
كده تمام. هاي.
شكرا لسيادتك. اوكي. Welcome everyone. Dear doctor and professor, thank you for coming today, and good morning, and welcome to the PCOS Become BMOS Clinical Excellence Hub 2026. We are happy to have all of you with us today. And before the global discussion about the shifting from PCOS to BMOS become widely recognized, and we are here in American Association already trying to bring attention to this important concept and highlight the deeper metabolic and hormonal aspect of the syndrome, not only the ovarian appearance itself. We would also like to sincerely thank our speakers who were among the first to take take the initiatives and openly discussions important evolving topic in women health. And this is only the beginning. More discussion and scientific insights will continue during the AJAC EEGC American Association Gynecology Conference in July. It will be a unique. It will
الصوت اختفى يا دكتوره نجوان.
اوكي كده تمام.
كده تمام.
معلش البيجننج بس يا دكتور
هم
حاجه جميله خالص.
بتاع اللينك.
اوكي.
اوكي.
I just want to highlight that more discussion about this topic will be conducted in a very great a large conference, EEGC, American Association Gynecology Conference, which will be conducted in July 26. This will be a unique and a very and international global event that will bring together 4 conferences in the same time and under one scientific platform. These 4 conferences will be IVF and infertility conference and aesthetic gynecology conference, endoscopy conference, and all about breast. Okay. Finally, I would thank you for attending this event, and I want to thank my American Association medical team for their hard work and dedication to highlight about this phenomena and this syndrome, and them dedication to make a very inshallah successful event. Thank you all, and wishing you all the best, and I wish you all best of luck. شكرا دكتور. Thank you Dr. Abu Bakr Nashar for giving me this time, and wishing you all the best, and congratulations for your daughter. مبروك لبنتك يا دكتور. ان شاء الله ربنا يتمم بألف خير. الله يخليك.
Thanks a lot دكتورة نجوان, and today good morning and good afternoon for everyone joining us from around the world. Thank you for all being here today. Welcome the webinar of polycystic ovary syndrome, and now it is not polycystic ovary syndrome but polyendocrine metabolic ovarian syndrome, and that's why this encourage us to address this change, and I think it will be covered by Dr. Muhammad Salama. It is truly an honor and a privilege to welcome such an outstanding gathering. We have a lot of well-distinguished speakers in obstetrics and gynecology, in nutrition, in fertility, and in genetics also across the Middle East and around the world. Today's webinar will be among the first international scientific events to discuss the emerging transition from polycystic ovary syndrome to the PMOS. We will highlight the newest perspective, the research, development, and also the future. Today marks a very special scientific event. We are proud to present what we believe is one of the first and the most comprehensive international webinar in the Middle East. As the American Association are leaders in continuous medical education, we remain committed to advancing women's health worldwide through innovation, through collaboration, and evidence-based medicine. And that's why there is a lecture addressing the evidence-based management of polycystic ovary. We should go to the new name, the PMOS, associated infertility. We are proud to stand at the forefront of the scientific education on one of the most important and evolving condition affecting women globally. Today, the webinar will consist of 20-minute scientific session. We have 8 distinguished speakers, and it is very important. Every speech will be followed by a 5-minute questions and answer, a panel discussion for each speaker. And I am encouraging all of the attendees to actively participate and to submit their questions through the webinar. Please also note that the certificate link will be available in the comments section during the webinar. And now, before we begin our scientific session, we are delighted to present the official company profile video of the American Association for Continuous Medical Education. Yes? Hello? Where is the video?
Just second, doctor. Just second.
Yes, I would like to welcome my dear friend and professor, Dr. Hisham Arab.
Hello everyone, hope you're doing great. I'm Dr. Mariam Rez, business developer here in the American Association. Today, I'll give you a brief introduction about who is the American Association. We will know more about collaboration, accreditation, and our services. American Association is an international educational organization that specializes in continuous medical education. We are focusing more on hands-on, more than theoretical part. We have different offices. We have our scientific office in Delaware, USA, UAE in Dubai, Egypt. We have 2 branches. Also, we have our new office in KSA in Riyadh, and soon we will open our new office in Iraq. Here in American Association, we offer different services. We made more than 1,000 semi-hours program, in addition to 32,000 semi-hours. Also, we offer customized program according to your needs. Regarding the conferences, we made more than 7 conferences in different specialties. We trained more than 16,000 physicians from all over the world from more 22 nationalities. What about the webinars? We offer more than 25 webinars for free for all physicians all over the world. And here in American Association, we call the house. Let's see a video about American Association together. American association who offer new services called fellowships with collaboration with the most prestigious universities. Let's move to the most interesting part, the accreditation. We took full accreditation from Accreditation Council for Continuing Medical Education that's located in Chicago. Why it's important? Because the Accreditation Council, one of the biggest accreditors in the world, that gave accreditation to Harvard Medical School, Johns Hopkins Medical School, Stanford Medical School, Saudi Commission, and Dubai Health Authority. Not only that, but also we created that took this accreditation in Egypt, and one of the most important organizations that took this accreditation in the Middle East. Not only that, but also American Association took a lot of accreditations from different accreditation bodies, like American Association of Continuing Medical Education that's located in San Francisco. We consider the regional partner here in the Middle East for American Association of Continuing Medical Education. Not only that, but also we have an office in Dubai, so we took accreditation from DHA. We have an office in Saudi, so we took accreditation from Saudi Commission. We have an office here in Egypt, so we took accreditation from National Quality Institute that we are certifying training center. At the end, we took 2 ISOs, ISO 9001 in quality management system, and one of the most important ISOs, ISO 21001 in training and education. Why it's most important? As we are one out of 5 organizations in the Middle East that took this ISO. So what about collaborations? We made several collaborations, as there is no organization will collaborate with another organization without trusting their curriculum. We made with WHO, World Health Organization, Egyptian Ministry of Health, United Nations Population Fund in different initiatives. Not only that, but also in aesthetic gynecology field, we made a lot of collaborations, like World Society of Cosmetic Gynecology, Brazilian Academy of Cosmetic Gynecology, Indian College of Cosmetic Gynecology. Also with different ministries, like Iraq, Jordan. Not only that, but also we made with Thinking Academy, Bahia Foundation, International Menopausal Society. At the end, our collaboration will not stop here, as we will make a lot of collaboration in the future. We offer different diplomas in obstetric and gynecology, like Basic Aesthetic Gynecology, Advanced Aesthetic Gynecology, ART for Obstetric Gynecology, IVF and eggs for Obstetric Gynecology, Fetal Medicine Obstetric Gynecology Basic Ultrasound, Fetal Medicine Obstetric Gynecology Advanced Ultrasound, Maternal Obs and Gynae Ultrasound Basic, Maternal Obs and Gynae Ultrasound Advanced. So what about dermatology? Aesthetic medicine, laser and aesthetic devices, hair aesthetics, dermatology and trichology, non-surgical body contouring, advanced botulinum toxin, advanced filler, advanced regenerative aesthetic injectables, biostimulators. Let's move to surgery part. Hysteroscope, laparoscope, colposcope, hair transplantation, fat and nanofat augmentation, liposuction and body contouring. And all our scientific programs are checking and reviewing from scientific committees located in the USA. So all of these points increase from our credibility. The last service we offer here in American Association, Hubs. What the mean of Hubs? Hubs are online free webinars that include global experts from all over the world, Q&A session, educational video demonstration, attendance certificates. Not only that, but also any questions that you want. The last but not least, the conferences. American Association offers different courses in different specialities. We offer more than 7 conferences. In the conference, you can get your certificate, you will know the latest update and the guideline in the field that you want. Not only that, but also you'll get certificates, semi-hour certificates, attendance certificates. At the end, I don't want to speak more about the conference, so let's see that together. to thank you for being a part of American Association.
Yes, thanks you everyone. And we'll now begin our first scientific session. It is my great pleasure to introduce our first distinguished speaker, Professor Hisham Arab from Saudi Arabia. Dr. Hisham Arab is a senior consultant of obstetrics and gynecology. Dr. Hisham Arab is the director of the Dr. Arab Medical Center. Dr. Hisham Arab has a lot of interest in IVF, in fetal medicine. And today, Dr. Hisham Arab will address decoding polycystic ovary syndrome, how to overcome the diagnostic challenges with technology. Please join me in welcoming Dr. Hisham Arab.
السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على أشرف خلق الله محمد بن عبد الله صلاة الله وسلامه عليه. First of all, I'd like to thank my dear friend أخي العزيز صديقي مدى الحياة الدكتور نشار أبو بكر. في الواقع I'd like also to thank the organizing committee and especially دكتورة نجوان المهندس دكتورة مريم for their kind invitation to let me to speak on this eminent actually gathering, which is actually something unique because it is marking the introduction of a new acronym for an enigmatic disease that has been really we have been suffering from to how to diagnose early and how to manage properly the PCOS, or what we call it now as the polyendocrine metabolic ovarian syndrome. So diagnostic challenges actually is the problem, as we all know. So to decode this PCOS or the PMOS, we have to introduce technology. And this is really the core of my talk. This is just to show you the introductory slides about how the Rotterdam criteria in 2003 has been modified 20 years later in 2023 by the International PCOS network definition by adding the elevated anti-Mullerian hormone in their definition, and also by separating the adolescents from adults in terms of definition, because in adults, you all know you have to have 2 out of the 3, the oligonucleation or hyperandrogenism and the PCO appearance. But here you have, for the adolescent, you have to have all 3 in between the age of 10 to 19, and you never start to call the patient in this frame unless she passed 2 years after her menarche. Now, if you like numbers, I can mention to you these things, like based on Rotterdam criteria, the prevalence of PCOS is 10 to 13%. It affects 170 million women reproductive age around the world. 40% of female infertility is due to PMOS, and actually 20% of women diagnosed with PMOS presented with glucose metabolism disturbance. Not only that, but we have also features that has been sometimes been stigmatic to this disease. But anyway, we have to include dermatological appearance, acne, alopecia, hirsutism, metabolic features going all the way from dyslipidemia, type 2 diabetes, metabolic dysfunction, as well as cardiovascular diseases and sleep apnea. Not to mention the reproductive features, which is mainly the ovulatory disturbance, irregular periods, infertility, and also pregnancy complications, as well as endometrial cancer. Finally, the psychological part, which is really like depression, anxiety, and poor quality, which have been really overlooked all over these years, till maybe Ishri has, elaborated on this 2020 or 2021 to guys look at this part. But anyway, so we have really messed up the diagnosis of this all over these years. And that's why the change has to come from PCOS to polyendocrine metabolic ovarian syndrome. Now, this call has really started long ago, 14 years ago, by the United States NIH, when they highlighted the challenges and inaccuracy of the current name, the PCOS, and recommended a change. At that time, they did not call it PMOS yet, but they recommended a change. So for that, we had to call, to go through a very complex process around the world that requires lots of funding, governance, broad engagement, as well as adherence to robust methods of processes. Many countries, workshops has been held, surveys, Delphi consensus, many stakeholders, patients' involvement, as well as academic institutes, all has really had their, input in this, transformation. A new name must support long-term clinical care, research, global adoption, and enable smooth transition from an existing terminology. So why we name it PCOS, name the PCOS to, or move it to PMOS? 5 reasons. PCOS reflects only one organ and fails to capture the disorder's multi-system nature. 2, PCOS falsely implies the presence of pathological ovarian cysts, which are not. So this is a misleading and confusing. The confusion can delay diagnosis, hinder effective communication, and contribute to patient dissatisfaction, as well as the reproductive focus of the name, which of PCOS, actually may enforce a stigma related to the infertility and the fertility capacity of a woman. This misnomer complicates the epidemiological classification, research, comparability, and health system coding. We have seen, if you really work in research, maybe you have, suffered from that because you don't know how to classify your stratification or to what area you should subject your research. It has really been a problem, and I think hopefully with this transformation we can have some kind of guidance in this. Moreover, the meta-analysis of large-scale genomic analysis and recent definitive studies confirm that the PMOS has a polygenic origin across the neuroendocrine, metabolic, and reproductive pathways. We have seen the prevalence of this disease varies from one country to the other, from one nation, for example, is the prevalence is in India is not as in Canada or in Africa. So that's something really has to be kept in mind and to hold significance. Insulin resistance and compensatory hyperinsulinemia present in 85% of affected individuals. So it's not just like fertility or polycystic ovaries, which is really amplify the androgen secretion and disrupt steroidogenesis, highlighting the metabolic endocrine interplay. Finally, the altered AMH concentrations, which is an ovarian endocrine function, adipokine signaling, and gut hormone interaction influence the clinical features, including reproductive as well as metabolic manifestation. From here, we can see how can we overcome this challenge or diagnostic challenge. Of course, the answer is technology. With technology, we reduce the subjectivity. AI reduces dependency on individual clinician expertise or ultrasound interpretation or system classification. Early detection. Advanced algorithm can identify subtle patterns that indicate PMOS risk, allowing for the early intervention and management to prevent long-term complications like type 2 diabetes, cardiovascular disease, and then being non-invasive diagnostic tool. Now research is improving toward using less invasive data, such as blood tests or even scleral eye imaging, rather than the transvaginal ultrasound, and digitized management. Mobile applications like the Ask PCOS or Flow or Clue, many of which use tracking data, which help patients manage symptoms, track periods, and provide valuable aggregated data for future research. Now, here I can just compare to you the two traditional approach versus the artificial intelligence. With tradition, we can use the ultrasound interpretation is really operated dependent. Laboratory thresholds also vary across population. Phenotypic heterogeneity, really, we have really found that one complicates the reproducibility of the research or of the work. Now, with the AI, we can identify, classify, classify PMS patients accurately and quickly by analyzing the complex clinical, hormonal, and imaging data, personalization of the treatment and prevention of metabolic, psychological complications, and also reduce the economic burden of the management and the treatment cost by early diagnosis and targeted intervention. So what kind of tools we use in this technology I'm talking about? There has been innovations that really went beyond the manual to some kind of what we call automated high precision detection. What are they? First of all, the branches of AI, machine learning models, which is an algorithm such as random forest and the SVM. Also, the gradient boosting, which include SG boost and the CAT boost, which utilize to analyze the clinical data and predict the PCOS or PMS with high accuracy, often reported by literature between 90 to 98%. Deep learning, this is for imaging, all right? Convolutional neural network, CNNs, are employed to analyze ultrasound images, automating follicle counting, and measure the ovarian volume. These models often exceed 90%, 95% accuracy in detecting the PMOS. Hybrid and fusion models, combining clinical, biochemical, and ultrasound data into a single AI model, has been shown to improve the predictive performance, with some hybrid approaches achieving the area under the curve of about 0.99, which is very high. And then, of course, the explainable AI, XII, which is techniques like SHAP or LIME, are being applied to make the AI models transparent. So it is really patient-friendly and doctor-friendly to work with. Now, the machine learning and the deep learning algorithm, usually these are intelligent technologies, particularly enhances the accuracy and efficiency of PMS diagnosis. And you can see here in one of the studies by Lai from China, published last year, they used the machine learning in about 85% of the cases, while they depend on the deep learning for only 15% of the cases. So how we do this? Simply, the machine learning technique in PCOS detection or PMS detection primarily focus on classification and feature selection, while the deep learning in PCOS detection primarily concentrate on processing and analyzing medical images and structured one-dimensional data, substantially enhancing both the accuracy and the efficacy of detecting process. Now, let's take the example of the Ming Lai, the Chinese publication, and how they did their work to include the AI. What they did from their taxonomy, actually, they comprise 8 categories, and you can see them here, of the PCOS, and they have features in each of one of those categories, and about 108 distinct features related to PMS. Imagine. And for example, these major 8 categories include the biochemical indicators, psychological and emotional health, dermatological and basic health, lifestyle, physical characteristics, menstrual and reproductive health, imaging indicators, and then vital signs. So in each of those, you can see the graph here on the right side, the blue number, is the number of indicators that related to each category. So for example, lifestyle, they have 5 features there. While for example, the biochemical indicators, they have about 34 features there that's been used. So these 108 distinct features being utilized in the machine in order to produce the outcome, which is a disease or no disease. And you can see here in the work of Lai that our findings revealed that 12 publicly accessible databases cover only 54% of the 108 features identified in our taxonomy. So that means we have, even the literature is poor in finding the details. I mean, they have suffered. They said only 54% publication, they have these details. And here, let me just give you an example how the technology works. All right, and I'd like here I'm using the work of Muhyiddin from Bangladesh, actually, who's actually put this very nice illustrative data starting from the left here, which is the data set. This is how they do it in our friends, the engineers in computerization. So they go to a data set. This data set is our work. It's patients with their details, the history of physical and biochemical testing, everything. The most famous one is the one is called Kaggle, which is really found on the web. And most of the work or the publications actually who tried different technologies, they use this as their source of data, because you have to feed information in order to get information. So after they go to this actually data set like Kaggle, the procedure starts with careful data preparation, which makes sure that the input data is clear, consistent, and model ready. This includes labeling coding for categorical variables, median imputation, as well as going for the missing values and trying to standardize the scaling of numerical features. Then comes the smooth. We can here see the data balance. This is a synthetic minority over sampling technique, which addresses class imbalance, which is a problem that often arises in medical databases, enhancing the model's capacity to accurately detect the instances of minority. So you can see here there are 3 different steps just to work on this data to make it more stratified and understandable. Then comes the mutual information, or the extra tree classifier, which is the green box here, to identify the top 10. Here, where it varies between one literature, one publication to another. Each center, they choose what kind of features to work on, to bring it as this is the most predictable features for PCOS or PMS. And here actually provide the most important information and a significant strength, because it improves the diagnostic performance of the model later on. And then comes the training model. As you can see here in the list of about 10 or 20, different models that has been used. For example, the multi-layer perceptron, the gradient boosting, also the XG boost, etc. So from all these, actually, the what we call the LMLP and the subvoting comes the first. The research investigators actually have the contrast between these two and put them together after identifying the top 10, and then work with this certification or detailing process. Then this will put them like and around the table, and let's see how each one is really come up and put the order for them. So this is samples exhibit resilience and dependability with the high diagnostic accuracy. Here comes the accuracy of the diagnosis of this procedure, and they have claimed actually in this in their publication that it was 96.88%, which is very high. Then comes the validation process. The validation process actually really comes here, the 5 squares in the bottom here, the area under the curve, the accuracy, the F1. This is a statistical method to validate these findings that has been produced. After that, which is finally comes what we call the web master, or the website, the development of a finished model, how you display these facts or your answer. This is what we call the Lime and SHAP. These are methods of displaying your answers, and they have really been used in this website to bring you the outcome. Now, when we go through this, the work of Muhyiddin, we can see here that through the use of SHAP, we can identify the top 10 features that really predict PMS. For example, the follicle number 1, and then cycle regularity, and then the hair growth, and then skin darkness, and then the weight gain, and then the LH. So you can see the order of significance of any of each of those features of PMS that really predict cited the PMS in their publication. And at the same time, when they run the LAM technique, they found, for example, again, the first three was the follicle number and LH and cycle are the highest. From these two, actually, they can come up with the final result, which is really, as you see here, you are the user. You have a computer in front of you. There is a web interface. You enter your data of your patients, okay, all in details. This will be transferred through the Flask, which is a method of writing the website or writing an application that will send this request to the machine learning model. This is the machine learning model, which is really, if you want to do what they're doing, which is exactly what I have mentioned in the past 10 minutes, okay, going through different certification methods, different equations, looking at the evaluation, at the data processing, and all that. And then they come up, as I said, at the end with the result in SHAP and Lima, and send it back to the screen. And then on the screen, you can say the answer, you find the answer. Yes, a PMOS patient, or no, she's not a PMOS patient. So this is how really we work around this technique. And I'm sure it is coming up. Maybe we'll need some time to learn about it. But I mean, the statistician as well as the computer engineering has really made it simple for us as a clinician. Really, we don't understand all these equations. But anyway, at they really we have to go through very rigorous experimentation in order to come up with the final results. Finally, I'd like to conclude here, ladies and gentlemen, by saying that while promising, the integration of technology into clinical practice faces hurdles. Okay, so data quality and diversity. Many models are developed using small, single center or overused public data sets like the Kaggle I mentioned before, which limits their generalizability to diverse populations. 2, lack of standardization. The absence of a single gold standard for PMOS diagnosis makes the developing university applicable AI models challenging. Lastly, or thirdly, clinical validation. Most artificial intelligence models are not yet implemented in routine clinical practice and require more rigorous large-scale clinical trials and validation. This is the final note, which is future research. Aims to integrate multi-omic data. Here, talking about universally, we are talking about the genetic background, so everything, all right, to enhance the explainability and develop personalized AI-driven digital healthcare ecosystem. And thank you very much.
Thanks a lot, Professor Hisham, for this nice updated presentation addressing the use of artificial intelligence in management of Police-Over syndrome, or the new name, which is the PMOS. And now, if there is any questions or comments for Professor Hisham Arab, we can go to the chat, please. Yes, there is Shukran, Barakallahu Feek. This is Doctora from Libya. And
can we unmute?
Unmute, please.
السلام عليكم.
وعليكم السلام. اهلا وسهلا.
مرحبا، انا الدكتوره جمانه الغلييني من الرياض
اهلا وسهلا دكتوره جمانه.
اهلا بك. حابه اشكركم اولا على هالمحاضره، على هالموضوع الرائع اللي اثرتوه، وشكري اولا كل عام وانتم بخير ومبارك عليكم 10 ذي الحجه جميعا. وثانيا شكر جزيل للدكتور هشام عرب، very informative و elegant lectures as usual دكتور هشام. Thank you very much.
You're welcome.
Thanks, Dr. Jumana. If there is, and I am going to the chat. Assalamu alaikum, Dr. Masuma. Thank you. الكاميرا المحاضرة مش أيوة. If there is any questions or comments, please. Please unmute all of.
السؤال دكتور نشار، السؤالي للدكتور هشام. You said all the benefits of the AI in clinical diagnosis of PMOS. What about the drawbacks or the unexpected or unknown yet the unwanted points? I mean, the cons and the pros of this method.
Very nice questions, and we should address this point. Dr. Hisham, please.
Yeah, actually, this was my last slide, actually, which I concluded that there are lots of hurdles that really facing our in technology, which is, for example, we don't have a gold standard. It does not cover diversity. Also, we need to do a more rigorous data analysis. The data sets that are available, maybe they are coming from one center. It's not really like meta-analysis or systematic reviews. Also, we have the problem with the research. I mean, unfortunately, the current publication, they are growing, yes, but they are using the same data, the Kaggle website, which is really can be sometimes misleading because you are not covering the diversity of populations coming from the west to the east. So yes, there are some limitations to the technology. We have to wait a little bit, maybe a little while before we rely mainly on technology.
Dr. Hisham, what's about the cost? Dr. Hisham,
yes.
What's about the cost? Are you thinking the use of the AI will decrease the cost or increase the cost of the management of the PCOS?
I think it will decrease the cost, Dr. Bakar.
So
yes,
you
it
are
will.
Very optimistic, Dr. Hisham.
When we talk AI, maybe in the beginning we used to talk about big machines and big money there being spent. I mean, once we have that technology available on hand, I mean, as like everything else, the car starts with a high price. After a while, the price will go down. This will eventually will happen. But what we'll see here, once you have a quicker diagnosis, so the patient will not be costing her to run from one doctor to the other in order to reach a diagnosis. Also, the treatment, maybe we'll go straight instead of trying this and this and that. No, just we go straight to the treatment that's been raised, according to the diagnosis, been raised by the technology. So AI here will save time as well as money, actually, for the patient and the healthcare provider.
Thanks a lot, Professor Hisham. And we will shift to the next speaker.
Shukran.
The next speaker is Dr. Amna Mansour. Dr. Amna Mansour. It is my honor to introduce Dr. Amna Mansour from Libya. Dr. Amna Mansour is specialist in obstetrics and gynecology, holding advanced expertise in reproductive medicine. Dr. Amna actively involved in the regional and the international medical education and focusing on advancing women reproductive health. Dr. Amna will address PMOS across the lifespan from adolescence to menopause. Please welcome Dr. Amna Mansour from Libya.
السلام عليكم ورحمة الله وبركاته. كيف حالك دكتورنا الفاضل؟ شكرا، بارك الله فيك دكتورنا. شكرا الأمريكان أسوسيشن. حنبدو إن شاء الله في المحاضرة اللي هي PMOS across the lifespan from adolescence to menopause. هل إن المشكلة هي what's the problem? It's just in one period or it's continuous with the patient from young age until she is reached to menopause. Polyendocrine metabolic ovarian syndrome is the new name from the condition previously known as polycystic ovary syndrome, which impacts 1 in 8 or more than 170 million women worldwide. Incidence, it's highly incidence. It's between 5 and 18% of the woman. That's why the patient start to confused and she is complaining and running from doctors to try to treat this problem. The problem with the old name it's misleading terminology. The cysts described in the original name are not actually cysts, they are symptoms. Incomplete diagnosis, many women experience the condition without ever showing cysts on an ultrasound, while others may have cysts without the hormonal or metabolic symptom associated with the syndrome. The fertility focus, because the condition was framed largely around the ovary, many patients found their concern many mixed unless they were actively trying to conceive. Symptoms tied to metabolism, mental health, and long-term well-being were often overlooked. So it's PCOS old name, it's concentrated just on the ovarian. It's concentrated about the polycystic in the ovary. But PMOS is described the condition more widely. It's concentrated on all metabolism problem, on the thyroid hormone, in the insulin, in the systemic. So the problem, it's not fixed on just ovarian, but it's concentrated in all the body, on all hormonal disturbance. So BMOS, it's concentrated polyendocrine. Polyendocrine, this knowledge that the condition affects multiple hormonal systems across the body, including adrenal gland, brain signaling pathway, not just reproductive organs. Metabolism, this condition is especially signified. It validates structure with insulin resistant. Patient, she is complaining from insulin resistant, weight regulation, increased risk of type 2 diabetes, cardiovascular disease as central part of the condition rather than secondary concern. Ovarian reproductive aspect remains important, but not framed within broader endocrine and metabolic context. So we see this picture, it gives a clue about the changes from PCO to BMOS. BMOS, it's covering everything in the body, so it's more liable to concentrate it on the BMOS, not on the PCOS. Okay, what's the cause? We don't know the real cause of this problem, but there is many theory about this point. Maybe it's environmentally toxins, hormone, it's lead to hormone imbalance, increase the FSH ratio, decrease the FS secretion, genetic predisposing, الجاتس. كل هذا يأثرنا بسببنا هايبر اندروجينيزم, increase the testosterone, it's reduced the sex hormone binding globulin, it died with lifestyle. This is the big problem, because in this time and these years, it is increased the fast food, and fast food, this is the big problem. It's affected on the BMOS because it's increased the weight, and this weight, it's increased the hormonal imbalance, hyperandrogenism, insulin resistant, and all this one is lead to clinical features like hirsutism, acne, oligoanovulation, and irregular menses, metabolic, اللي هو risk of metabolic disorders. So when you are concentrated in the most important factor for this one, it's increased weight. So many patients, when we are reduced her weight, all hormones, it's become better. A patient, when she is come to us, she is complaining from infertility. When she is reduced her weight, it's get pregnant even without any treatment. Just when they are changed the lifestyle, this is the rule to reach to improve all her symptoms, and she is response good to the treatment. الفور تايب اوف بي سي او اللي هو الكلاسيك، في الكلاسيك تايب A وتايب B. تايب A اللي هو هاي اندروجين lack of ovulation polycystic ovary. كلاس تايب B اللي هي high androgen and lack of ovulation. non classic type C high androgen and polycystic ovary. non classic type D اللي هو lack of ovulation and polycystic ovaries. So we must know the types of PCO to know and reach the diagnosis and how to manage the patient. Types of PCO: insulin resistant PCO هي الموست common type. في الادرينال PCO اللي هي high stress hormone والهاي داهية is inflammatory PCO. والبيست بيل PCO هذه تكون temporary after stopping birth control. Coming off the pill, the patient he is improved. So الإشري we are we are concentrated how to put the patient if she has PMOS or not. We are concentrated on Rotterdam criteria, and present two of the following three, we can diagnose the patient as PCO before and PMOS now. Rotterdam criteria 2003, she is concentrated on oligo or anovulation, hyperandrogenism, clinical or biochemical sign, polycystic ovary on the ultrasound more than or about 12 small cysts, 2 to 9 millimeter in diameter, or increase ovarian volume to more than 10 centimeter. Diagnostic steps هذه about we are concentrated in the International Evidence-Based Guideline 2023. Step 1, irregular cycle and clinical hyperandrogenism. Step 2, if no clinical hyperandrogenism but there is test for biochemical hyperandrogenism. Step 3, if only irregular cycle with hyperandrogenism by ultrasound, there is polycystic ovarian morphology اللي هو PCOM, or we are do it AMH for the patient. Rotterdam criteria, we are classified about severe classical ovulatory and non-hyperandrogenic اللي هي depending على anovulation, hyperandrogenism and PCO. International evidence-based guideline for assessment and management of polycystic ovary syndrome in 2023, we are definition the irregular menstrual cycle as normal in the first years post-menarche as part of puberty transitions, more than 1 to less than 3 years post-menarche, or less than 21 or more than 45 days, or more than 3 years post-menarche to perimenopause, less than 21 to more than 35, or less than 8 cycle per years, more than 1 year post-menarche, more than 90 days for any one cycle, primary amenorrhea by the age of 15, or more than 3 years post-menarche اللي هو breast development. When irregular menstrual cycle are present, a diagnosis of PCO should be considered and assessed according to PCOS guideline. With this picture, it helps us for the diagnosis if the patient she is complaining of PCO in the adolescence. So menarche unable to diagnose PCO, first years menarche اللي هي نبدو من السكند years post menarche diagnose PCO لو كان شو لقينا irregular menstrual cycle more than 90 days, or any cycle menstrual cycle less than 21 to more than 45, or primary amenorrhea 3 years post menarche, and hyperandrogenism clinically or biochemicals اللي هو third years post menarche until 19 years diagnose PCO if irregular menstrual cycle more than 90 any cycle, or menstrual cycle less than 8 years or less than 21 to more than 35, and hyperandrogenism clinically or biochemicals. So don't use pelvic ultrasound for diagnosis of PCO in adolescents. Okay, we can manage the patient. We can see that the change of lifestyle for the adolescents is the main treatment for the patient, because they are come with overweight, and this overweight it's affected on the patient and give her stigma about all the hair surrounding, and its response to the treatment very poor because her weight it's very high and she is eats sugar too much, and this effect on the how to manage the patient, and this management is very difficult. So we are concentrated to the management for treatment the symptom, and we try to reduce her weight to become response more. Okay, and Ishri, it's very difficult to reliable assist for biochemical hyperandrogenism in the woman on combined oral contraceptive pills, as pills increase the sex hormone binding globulin and reduce the gonadotropin depending androgen production if already in compound oral contraceptive pills. Yet assessment of biochemical androgenism is the pill should be withdrawn for minimum 3 months and contraceptive should be managed otherwise during this time. Biochemical hyperandrogenism اللي هو high or increase the free testosterone increase the free androgen index for the detections of hyperandrogenism in the PCO, the assessment of biochemical hyperandrogenism of greatest value in patient with minimized or no clinical agent of hyperandrogenism. So we are concentrated to if there is clinical or biochemical hyperandrogenism. The presence of hirsutism alone should be considered predictive of biochemical hyperandrogenism and PCO in adult. Comprehensive history and physical examination should be completed for symptom and sign of clinical hyperandrogenism اللي هي زي الأكني, female pattern hair loss, hirsutism in adult, and severe acne and hirsutism in adolescents. Okay. Polycystic ovarian morphology, transvaginal ultrasound features follicle number per ovary more than 22 to 9 millimeter in at least one ovary should be considered the thresholds for polycystic ovarian morphology in adult, and this one, it's increased guideline, international evidence-based guideline 2023, or ovarian volume more than 10 millimeters on either ovary, like ensuring there is no corporalatia, there is no cyst, or dominant follicles are present. AMH هي big one. All the doctors try to concentrate it on the AMH for the diagnosis of polycystic ovary. Serum AMH should not yet be used in adolescents. Either serum AMH or ultrasound may be used in defined polycystic ovarian morphology. However, both tests should not be performed to limit overdiagnosis. We are concentrated about overdiagnosis. All the patients, all the girls, they are concentrated. You are complaining from polycystic ovary. Laboratory and healthcare professionals need to be aware of the factor that influence AMH in general population include age. Serum AMH generally peak between the age of 20 to 25 in the general population. Body mass index, we are concentrated. Serum AMH is lower in those with higher mass index in general population. Hormonal contraceptive and ovarian surgery. Serum AMH may be suppressed by current or recent combined oral contraceptive use. Menstrual cycle day serum AMH may vary across the menstrual cycle. Laboratory involved in AMH measurement in female should be used population and assess a specific cut-off. FSH والاستراديول within normal level والLH sometimes elevated above FSH اللي هو LH-FSH ratio not diagnosed for PCO. So we are concentrated about the patient to diagnose the patient for PCO or PMOS. We are concentrate about all the symptoms and all the investigation, not just one investigation. We are diagnose the patient as PCO. We are concentrated about anti-obesity pharmacological agent up to 50 to 70% of women PCO above healthy weight. هذه المشكلة. This is the problem for the patient. Most of the women, they are above the healthy weight. So anti-obesity medications اللي هي كل هذه receptors agonists could be considered in addition to active lifestyle intervention for the management of the higher weight in adults and PCO as per general population guideline. So we are not given for her medication without change her lifestyle, must be change her lifestyle, and we are given treatment to try to reduce her weight. Inositol in any form could be considered in women with PCO based on individual preference and values. Nothing limited her harm potential for improvement في metabolic measure, yet with limited clinical benefit, including in ovulation, hirsutism, and weight. Metformin should be considered over inositol للhirsutism and central obesity, noting that metformin has more gastrointestinal side effect than inositol. So most the patient, she is not like to take metformin because its effect on her gastric and increased gastric upset. So most the patient, she is trying to use inositol better than metformin, but metformin it reduced the central obesity better than the inositol. البايريتريك سيرجري اللي هي could be considered to improve the weight loss, hypertension, diabetes, tag for prevention and treatment, hirsutism, irregular menstrual cycle, ovulation, and pregnancy rate in women with PCO. Women should be strongly counseled on the likelihood of rapid return of infertility and need to commit to effective contraceptive ideally prior to the surgery, even when pregnancy is desired. Contraceptive should be continued until stable weight is achieved, usually after 1 year, to avoid significant risk of growth restriction, prematurity, small for gestational age, pregnancy complication, and prolonged hospitalizations of the infant. We are concentrated about the hyperandrogenism in women with PCO persisted after menopause. Post-menopause overweight women with PCO are characterized by abdominal adiposity features that appear persistent even after menopause. So higher in post-menopausal PCO than in PCO woman. يعني البيشنت لاحظ ان all the metabolism is changes and continuous with the patient even after menopause. So the adrenal androgen hypersecretion does not seem to be related to central originate hypothalamic pituitary adrenal as dysfunction as indicated by the normal ACTH and cortisol response. Ovarian androgen production has persisted after menopause in women with PCOS as reflected to the higher level after dexamethasone suppression. So adrenal ovarian hyperandrogenism persists in PCO women for at least 5 years after menopause. We are concentrated about the definition. What's the pre-menopause? No symptom present, considered the reproductive years, or perimenopause اللي هو transition period to menopause when symptom can appear, or menopause occurs at the end of perimenopause or post-menopause. Okay, دكتورة حبيبة. Okay. PCO and menopause. Irregular menstrual periods are common in younger people with PCOS. As people with PCOS near perimenopause, their period become more regular. People with PCO may also have longer reproductive period, reaching menopause about 2 years after their birth without PCOS. Some research suggested people with PCOS who experience difficulty with fertility may have increased chance of conceiving as they get elderly. Okay, PCO continues after menopause. Factor associated with PCO commonly appears during perimenopause. For people who don't have PCO, this includes increased insulin resistance, body does not respond fully to blood sugar regulating hormonal insulin, fat gain around the middle abdomen, increased cholesterol level, high blood pressure, irregular or absent period, symptoms such as facial hair growth. People with PCOS have increased risk of cardiovascular and type 2 diabetes. The more important point, we are concentrated in the PCO, its effect on the mental health. This is the problem for the patient. PCO significantly increase the risk of anxiety, depression, and other mental health challenge due to hormonal imbalance, inflammation, and psychological impact of the physical symptom. So this picture, yes, this picture, because we don't have time, this picture, it's affected in PCOS. It's increased the all the mental health, like depression, anxiety, and this effects on the mental health from the adolescence to until increase her age. A link, a biological mechanism, it's depending on elevated androgen, insulin resistant, disrupted reproductive hormone can affect neurotransmitter function, particular serotonin, which regulate the mood. Dr. Habiba, biological. Next slide, please. So the biological mechanism, so this elevated androgen, insulin resistant, and disrupted reproductive hormone, all these effects on the neurotransmitter function, particular serotonin, which regulate mood. Next. So a chronic, another biological mechanism اللي هي chronic low grade inflammation impact on the brain chemistry and stress response with elevated markers زي C-reactive protein interleukin 6 correlated with depression. This regulation of the hypothalamic pituitary adrenal axis, it's lead to increased stress sensitivity and mood instability. So psychological and social factor البي سي او سيمتوم زي الويت جين والاكني والهرسيتيزم والفرتيليتي، هذه كلها it's increase of the social anxiety and health related worry. PCO, next. PCO, it's increased 14% suffered from depression, 42 suffering from anxiety, 13% suffering from panic eating disorders, 99.9 have poor body image, 12% suffering from distorted eating. So we need to support her. We are trying to eat healthy food, try to move, try to decrease her weight, and we can give to her medications like antidepressant, blood pressure medication, diabetic, anti-androgen, and cholesterol medication. And thank you. And we hope our lecture is short and not concentrated too much on you. شكرا دكتورنا، بارك الله فيك.
Hello, Dr. Amina, for this comprehensive presentation. And we can allow for one question because we are behind the schedule. If there is a question for Dr. Amina or comment. If there is no questions, just a comment to Dr. Amina. You mentioned that for diagnosis of polycystic syndrome by ultrasound, we should have the number of the follicle number per ovary 20. This provided that your machine, the frequency is more than 8 megahertz. But if your machine, the frequency is less than 8 megahertz, the cutoff level for the follicle number per ovary is 10 only.
Okay.
There is any other questions for دكتورة آمنة؟ حضرتك منين يا دكتورة آمنة؟ من طرابلس ولا من بني غازي؟
أنا من طرابلس.
أحسن بلد، يا أهلا وسهلا بيك.
والله شرف لي أكون معكم حقيقة. وأنا كنت من الناس اللي خدوا معكم دبلومة في الأمريكان أسوسيشن for aesthetic and fertility and الحق حقيقة هذا يساعدني هلبة في شغلي. شكرا، بارك الله فيكم، ربي يحفظكم.
We welcome Dr. Osama Shawqi and I am the next speaker. So without introduction, I will go direct to my talk, and it is related for what is raised by Dr. Hisham Arab. I will do the share screen, yes. Yes, the slide is clear and the voice is clear. So, as the title of this webinar is the polycystic syndrome in the era of the AI and the electronic era, we will discuss what's called prediction models for the polyendocrine metabolic ovary syndrome. It is a new subject. And we'll address after the introduction, is it important, this prediction model? And what are the methods used? I will not go to the details. We are doctors who are clinician, and I will leave all this for the engineer interested in this subject or the statistician. Then what are the types of the prediction models? And the most important, and I think it was addressed by Professor Hisham Arab, the validation of these models. Let us start by the introduction. Prediction models for the PMOS using the combination of clinical features, biochemical markers, imaging finding, and lastly, the AI. And our objective is to estimate the diagnosis, the complications, the metabolic one, and the most important, the reproductive outcome. Is it important to have prediction model? The answer yes. Why? Because as we know, the PMOS is heterogeneous syndrome. And as mentioned by Dr. Amna, we have 4 phenotypes of the PMOS. And also not only this, and we have a long-term risk for the PMOS. So the prediction model will help, number 1, for estimation the likelihood of the PMOS. Number 2, identify the risk, the insulin resistance, type 2 diabetes, the cardiovascular risk, the endometrial risk. All of these are the long-term sequelae of the PMOS. And by the prediction model, we can anticipate this risk. Not only this, but also the prediction models can predict the response to the ovulation induction, to estimate the risk of the ovarian hyperstimulation syndrome, and lastly, to predict the IVF outcome. So the next step is, or the next item to be discussed, the methods for the evaluation or estimation of these models. Number 1, what are our predictors? Our predictors may be clinical, like the age, the body mass index, the Hirschism score. It may be hormonal markers like the free androgen index, the AMH, or it may be metabolic markers like the hemoglobin A1C, the fasting insulin, or it may be ultrasound features like the interfollicle count, or in the future maybe the genetics and the omics data like the microbiome profile. So these are our predictors. Then what are the traditional statistical methods? I will not go to the details, but I will just give a general idea about these traditional statistical models. We have what's called the logistic regression, which is commonly used method, and we have some formula, some equations to determine the risk and the model. And we have what's called the nomogram, which are graphic tools derived from the regression models for the bedside use. And as mentioned by Dr. Hisham Arab, the machine learning models in AI. Again, I will not go to the details, and these models may include the random forest, the neural network, and the machine learning models often achieve area under the curve from 0.85 to 0.95. And this is examples of what's called the random forest classifier. I will not go to the details. We are a clinician, we are not an engineer, and we just to have an idea about the prediction of the polycystic ovary syndrome using the random forest classifier. And this is another example of the use of the AI for the prediction of the polycystic ovary syndrome. And we have a lot of models using the AI, and the accuracy and the strength of these models are variable. And thanks to this study in 2025, evaluating the accuracy and the strength of the different models. The third item to be discussed, what are the types of the prediction models in the PMOS? We have diagnostic models, estimating the probability that the woman has PMOS, and we have prognostic models. We are predicting the future outcome, like the development of diabetes, the pregnancy after ovulation induction, the live birth after IVF, and the miscarriage rate. And also we have the third type, which is the treatment response model. For prediction, what's the response to letrozole? Letrozole is the drug of choice for treatment of polycystic ovary syndrome associated infertility. And what is the response to clomiphene citrate? What is the response to gonadotropin? All of these can be predicted using the prediction models. Let us go to the diagnostic prediction model. Some is based on the AMH. And as we know, according to the International Polycystic Ovary Guideline, AMH may be used as an alternative to ultrasound for defining the PMOS morphology in adults. But AMH can be used alone or combined with the androgen measures to achieve a good discrimination. The diagnostic prediction models is dependent also in a combination of clinical models, not only on the AMH, but on the clinical manifestation, the oligomenorrhea, the clinical or the biochemical hyperandrogenism, the body mass index, and the AMH. It was mentioned by Dr. Hisham about the use of the deep learning ultrasonography models. And the second type of models is the models predicting the metabolic risk. These estimates the insulin resistance, the type 2 diabetes, and frequently used predictors are the body mass index, the waist circumference, AMH, testosterone, and fasting insulin. The third type of models, the models for the ovulation induction prediction. And as we mentioned, the letrozole response, depending on the body mass index, the AMH, the testosterone, and the clomiphene citrate, depending on the obesity, hyperinsulinemia, elevated AMH, and severe hyperandrogenism. The last type of model, which is the IVF outcome prediction model in the PMOS, using the risk or estimating the risk of OHSS, the oocyte yield, the live birth, the miscarriage, and the important predictor for the IVF outcome, the AMH, the antral follicle count, the body mass index, and the age. And one of the most important predictor is the previous response. So we can summarize all of these in the following. The prediction target. If I am looking for the polycystic ovary syndrome diagnosis, so the predictive are the menstrual irregularity, AMH, testosterone, and the body mass index. If I want to predict the insulin resistance, so the predictor are body mass index, waist circumference, and the fasting insulin. If I want to know the response to clomiphene citrate, so the predictors are AMH, testosterone, and obesity. For assessment of the OHSS risk, we should depend on the AMH, antral follicle count, and the age. For estimation or prediction of the live birth after IVF, the most important are age, body mass index, and the embryo quality. Let us go to the last item, which is important, as mentioned by Dr. Hisham, is the validation and the reporting standard. The prediction model should be developed and reported according to, I will not go to the details, what's called the tripod statement, and assessed by what's called the PRO-PAST. All of this out of our interest, but just to have an idea how the prediction models are developed and how the prediction models are assessed. But the key performance measures for any model is the sensitivity and specificity, the area under the curve, what's called the calibration slope, and the decision curve analysis. We mentioned the area under curve many times, and we have some cutoff levels for it. If it is 0.5, no discrimination. While if it is the AUC from 0.8 to 0.9, it is excellent. And when it is 0.9 or more, it is outstanding. So we should mention the limitation of the existing model. Number one, most published models suffer from small sample size, single center development, variable diagnostic criteria, limited ethnic diversity. As mentioned, there is a quite difference between the ethnicity, those living in the Asia and those living in America and in the Middle East. And there is also a lack of prospective external validation. For any test to be validated, we should have external validator. That's to say, to be confirmed its value and its efficacy by another centers in the world. What are the future direction? We have emerging approaches, including the metabolomics, the use of the smartphone-enabled symptom tracking, and the polygenic risk scores. To come to the conclusion, number one, prediction models may support early diagnosis, personalized or individualized ovulation induction, prevention of ovarian hyperstimulation syndrome, long-term metabolic risks stratification. And it is recommended to use combined clinical biochemical models, not a single marker. And AMH is a strong marker, but it should not be used in isolation. External validation is important and is essential. And most models remain investigational, experimental, and should complement, not replace. It is an additional. These models will not replace the guideline-based clinical assessment. We should keep in mind these models, it is an adjuvant, but it will not replace the guideline-based clinical assessment. And lastly, most advanced AI models are not very ready for widespread. It is not available everywhere. And as I mentioned, one of the barriers of this is the cost. So most advanced AI models are not available everywhere for clinical implementation. Thanks for this, and these are the references from where I got my slide. So we will allow for any comments or any questions. Yes? Please unmute.
دكتور بكر.
ايوه دكتور محمد صلاح. محمد سلامه. Welcome.
يا هلا.
Professor Muhammad Salama, Professor of OB-GYN from Manufia University. If you have any question or any comment.
Yes, please, if you allow.
Yes, please.
Very nice, and it is complementary to Professor Hisham Arif too.
Yes.
It is the future for prediction and management. But up till now, you asked Professor Hisham what is the cost, and he said it is will be lower. What is your opinion?
I think no.
Yes.
Dr. Hisham, as I mentioned to him, is optimistic, but we should be realistic. As you know, you should, to have this application, you should pay, and also this is for a fixed time. And when you want to renew it, to renew this, you will pay again, and so on. And that's why we should stress, it is an adjuvant, an additional, and we should depend on our clinical expertise and the evidence-based baseline. If there is any other questions, if no other questions, we can shift to the star of this webinar.
ازي حضرتك يا دكتور؟
دكتورة سدرة اسم جميل.
ازي حضرتك؟
اتفضلي يا دكتورة سدرة الشيخ.
شكرا جدا
اتفضلي.
على المحاضرة الجميلة
حضرتك
دي.
بتتكلمي منين يا سدرة؟
أنا من مصر، من القاهرة.
يا أهلا وسهلا بحضرتك.
أهلا بحضرتك يا دكتور، شكرا جدا، المحاضرة جميلة وتسلم بيد حضرتك.
لا أنا الحقيقة هي فيري يعني كومبليكيتد وأدفانسد، وأنا حاولت يعني ما أخشش في تفاصيل إحنا ما تهمناش. إحنا we are clinician at the end, we want to know what are the application. So if there is no questions, because we are behind the schedule, it gives me a great pleasure to introduce my dear brother and my dear friend, Professor Osama Shawqi. Professor Osama Shawqi is a professor of obstetrics and gynecology, Cairo University. Dr. Osama is a global pioneer. He is an international pioneer in hysteroscopic surgery. And Dr. Osama, well known all over the world. And Dr. Osama today will address, I know Dr. Osama is interested in the history, and that's why he will address today historical point of view on polycystic ovary syndrome. Please welcome Dr. Osama Shawqi.
يا صباح الفل.
يا صباح العندليب.
يا ترى منور الشاشه يا دكتور ابو بكر، والله منور الشاشه.
انا ما عنديش الحاجات الالوان الجميله المبهجه دي.
لا انا حاسس هياخدوك في مسلسلات رمضان السنه الجايه اكيد يعني.
الله يخليك. لا والله بجد.
يا ترى
اللون الاصفر او الكناري ده كناري ولا ده ايه؟ بس
انا جاي من القاهره بالقطر، وصلت اسكندريه حالا وطالع رشيد، عندي عمليات في رشيد، واجرت اوضه عشان اخش اتكلم معاكم. يا ترى كل الزملاء سامعيني ولا لا؟
ربنا يعينك يا دكتور اسامه.
دكتور ابو بكر، هو الويبينار ده دايركتد للزملاء في ليبيا ولا في كل
مش عارف يعني
كل العالم؟
طيب الاول احييكم كلكم واقول لكم
انت طبعا يعني الاستاذ العظيم انجلش لو تكرمت.
But I have to say the compliment in Arabic، يعني يا صباح البونجور على كل أمورة وكل أمور.
accepted.
ويجعل حياتكم بهجة وسرور. And I will try to stay يعني I will start my sharing screen now, and please let me know if the screen is seen or not. Share. Okay, allow. Is my screen shared now?
Yes, very nice.
Yes.
This is the ovary and the tube, and this is the
so
yes.
بسم الله الرحمن الرحيم.
Ovary
Let us start على بركة الله.
دكتور أسامة، في تحيات كتيرة من جميع أنحاء العالم، بيقول لك منور يا دكتور أسامة.
الله يخليك، بس الشيرنج مش شغال، هو هيشتغل اهو.
لا هو واضح عندنا.
طيب لو أي وقت مش واضح قول لي.
اتفضل يا حبيبي.
Well, a very lovely good afternoon, my dear colleagues, wherever you are in the world. And thank you very much for considering me in this particular exciting topic, PCOD. It's quite challenging to touch a topic which is shared between multi-speciality, a topic that's creating a lot of noise nowadays. I'm sure that many of you have seen this announcement that there is a breaking news. Can you imagine, my friend, that every time I open the Facebook pops out this breaking news, and I'm expecting something serious. So what is the breaking news? PCOS has now a new name. صلاة النبي، أنا كسبت صلاة النبي كده، مش كده ولا إيه يا غازي إبراهيم معانا من الأردن. This is quite amazing. Quite amazing. يعني أنا كل ما أفتح الفيسبوك ألاقي يقول لك إيه، أخبار طارئة، breaking news and the PCOS has a new name. What is the issue? They changed the name from polycystic ovarian disease to polymetabolic whatever PMOS. يعني معلش ده رد فعلي انا، يعني ده رد فعلي انا. هو يعني the issue that everybody should be aware about, that PCOS is about to be no more gynecological disorder. خليكم أذكياء. Be smart. Somebody wants to pull the carpet from under the leg of the gynecologist, okay? So they claim that PCOS will be no more gynecological disorders, and the fight will go between endocrinologists, dermatologists, and اسمحوا لي أشارككم how gynecologists feel after PCOS بقى اسمه PMOS. يعني أنا بحب أعبر لكم بس إحنا هيبقى شكلنا عامل إزاي. I am very big fan of history.
is not served يا دكتور.
Why I like to tell history and stories, because if we don't learn from history we will not build the future. أنا هقول بعض الكلام بالعربي. إذا لم نتعلم من الماضي مش هيكون لينا مستقبل. Let us be smart, and history teach us أهم حاجة how people think. إزاي الناس كانت بتفكر. How ideas develop. العلم مش دلوقتي ان انا ارص محاضره 1 2 3 4. My aim is to stimulate your mind to innovate. In this historical narration, I will tell you how people thought about this issue. It was in the Congress of the American Association of Obstetric Gynecology سنة 1935. لو كلمت عربي يبقى مكتوب بالانجليزي.
أسامة,
1935.
please, are you changing the slides or not?
I'm changing. ما يبانش حاجة؟
No change.
لا أنا changing the
Fix it.
slide. آخر حاجة شفتوها إيه؟
هي أول حاجة.
ما شفتوش صورة الدكاترة؟ صورة
خالص ما شفناش حاجة خالص غير صورتك الجميلة. لا دي خلاص بدأت تتغير
طب
دلوقتي.
يبقى أنا غالبا هشتغل بقى بالمود ده، مش هفتح الفول مود. خلاص؟
زي ما تحب يا دكتور أسامة.
يعني ما شفتوش التنويه الهام ده؟
لا ما شفناش ده.
خلاص. فزي ما قلت ان الاخبار طلع لنا بريكنج نيوز. يعني في بريكنج نيوز. PCOS has a new name now. They are claiming that it had changed, and this is my response when I heard that they changing the name from PCOS to PMOS. الحقيقة I personally find that there is a reason behind that. The reason is that they want to pull the carpet under our legs. That PCOS is no more a gynecological disorder. الصور واضحة يا دكتور بكر؟
واضحة جدا.
And then the fight will go between gynecologists, endocrinologists, and dermatologists. كده بقول لك لو السلايد مش ماشية قول لي يبدو
لا ماشي جميل خالص يا دكتور أسامة.
والحقيقه انا دي الصوره اللي بقول لكم ادي شكل الجينيكولوجيست بعد ما هيقولوا لنا ان PCOS ما بقاش بتاعكم انتوا. Why I like to tell history? Because if we learn لازم نتعلم الناس كانت بتفكر ازاي. How people think, how idea evolves. This is the way to make a generation to improve, to innovate. مش صح ان انا اقعد اجيب سلايد 1 2 3 4 5 تقدر انت تقراها في الكتاب. لكن انا عايز اشارككم. I want to share with you how ideas was born. It was in a Congress of the American Association 1935. Well, these two persons, Mr. Irving Stein and Michael U. Leventhal, they presented a case report. They described a clinical history of 7 women عندهم menstrual disturbances, hirsutism, and infertility. الحقيقة ستين and Leventhal, they didn't claim, هم لم يدعوا إن هم they discovered a new syndrome. Do you know who called it Steen-Leventhal syndrome? It was another person. It was Vincent Meigs. And Meigs ده ليه سندروم باسمه برضه اللي هو ميك سندروم. فاكرين ولا لا يا شباب؟ ميك سندروم ده اللي هو كان benign ovarian tumor with hydrothorax and ascites. So it was Joe Vincent Meigs اللي اقترح ان يبقى في مرض اسمه ستين and Leventhal syndrome. And this is the first article. انا جبتها تعبت عشان اجيبها لكم من الامريكان جورنال 1935. سنة 1935 12 ارتكل عن 7 حالات عندهم menstrual disturbances and phenotypical changes in the shape of the ovary. I want to draw your attention to something very important. يا جماعة at that time there was no ultrasound. ده كانوا بيفتحوا بطن الستات عشان يشوفوا السيستيك اوفريز. But let me take you even before 1935. هنا بقى we'll start the journey. هنبدأ الرحلة مع بعض. إزاي العقل البشري بيفكر. How to build the personality of innovative mind. من قبل شتينا ليفنثال كان in the year 1844 سنة 1844 كان أول published account of a clinical entity بدكتور فرنساوي فرنش دكتور اسمه اتشيلي شيرو ده 1844 وصفها في كتاب اسمه مالادي دي اوفير. يعني شوف قد ايه كان there was a textbook سنه 1844 عن امراض الاوفري. وهي mentioned typically description and morphology of the polycystic ovaries. قال بيبقى فيه الاوفرز enlarged with a smooth shiny surface و contain many small cysts. برجع افكرك تاني at that time there were no ultrasound فالتشخيص كان عن طريق لاباروتومي ويتفرجوا على شكل الاوفري. بعدها ب10 سنين في سنه 1895 لما بتكلم عربي اسمحوا لي اللي ما يعرفوش عربي مكتوب قدامهم كلام انجليزي كان في وصف تفصيلي ودقيق exact description of a cystic form of chronic arthritis. ما ساعتها ما كانوش فاهمين they didn't know so they thought this is an inflammation. والكلام ده اتنشر في تكست بوك كلينيكال جينيكولوجي باي دكتور ماكلنبورغ بولك من جامعه كورنيل. and he gave a detailed description of polycystic ovary. خد بالك انشتين ليفنثال سنه 1935 لكن من قبلها بسنوات في ناس لاحظت هذا الكلام ولاحظت هذا التغير. In 1897 Albert Goldspoon the professor of gynecology at Chicago suggested ان الcystic ovarian changes دي عباره عن complication of retroversion. خليك معايا عشان تشوف بقى العمليات اللي اتوصفت لهذا الموضوع. الحقيقه اول واحد بقى اتكلم على العلاج كان دكتور اشتون وكان ليه تشابتر كامل اسمه chronic ovaritis and he mentioned exactly the cystic changes وده كان اول واحد يربطها بالmenstrual disturbances and sterility. قبل كده ما كانوش بيربطوها بالستيريليتي وكان اول واحد تو ريكومند تريتمنت. تعالوا معايا بقى وابتسموا واضحكوا وشوفوا الناس كانت بتعالج البي سي او زمان ازاي. These are the historical remedies treatment for polycystic ovary. قال لك use of alcohol is forbidden يعني ما يشربوش كحوليات. Vaginal douche night and morning with a gallon of a hot normal salt solution. جالون يعني 5 لتر. 5 لتر يعني الست تتشطف كل يوم ب5 لتر. And insertion of a cotton tampon saturated with glycerine. Plenty of water. Diet. Bowel should be open يعني ياخدوا laxative وكانوا بيدوهم analgesics and relaxation by bromides and exercise. This was the treatment at that time. عايز اقول لكم على حاجه حلوه قوي في تاريخ الطب بقى. عند اكتشاف الكهرباء مش الدنيا بس اللي نورت لا ده الطب نفسه نور. So with the introduction of electricity the professional in medicine thought that they can use it in the treatment of diseases of the human body. وكان أول فكرة لاستخدام الكهرباء للبشر للعلاج كانت في الرواية الخيالية بتاعت فرانكشتاين من تأليف ماري شيلي اللي كانت سنة 1818 اللي هي قصة فرانكشتاين لما بيوصلوا له أقطاب كهرباء فبتعود لي الروح تاني. Ladies and gentlemen, let me show you the first machine. This at that time was like the modern ultrasound. This was the first electric machine for treatment of gynecological disorders. فتخيل ان الراجل ده جولدسبون advised half hour daily دوش كل يوم نص ساعة vaginal دوش بمية سخنة وبيركبوا أقطاب كهرباء على جسم المريضة يعني بيكهربوها thinking that this will correct the polycystic ovary. أنا بس عايز أقول لك قد إيه خيال الإنسان كان بيتبحر في أمور عشان يصل لوسائل للعلاج. However, the only modern achievement for polycystic ovary was in 1961 by the gentleman Dr. Greenblatt from Medical College of Georgia, who advised or introduced the use of clomiphene citrate. The effectiveness of the non-steroidal anti-estrogen clomiphene as an ovulation induction agent was recognized and applied for PCO. فده كان أول فكرة علاج طبي للبي سي او. ويمكن تندهشوا لما تعرفوا ان كلوميفين ستريت يباع في العالم تحت مسميات 79 نيم. There are 79 brand names from clomiphene citrate. Clomiphene citrate was synthesized في 1956 and it was registered, اتسجل 1959, approved for marketing 1967. ثم later on came the idea of surgical intervention. وهنا هسلكوا بقصص مسلية جدا ومبهرة جدا وهنهيها بالاسلوب الجراحي اللي انا كنت قدمته منذ سنوات في امريكا. طبعا surgical intervention for PCO was advised. However, many people were against it. Ovarian wedge resection was advocated long time before Steen and Levinthal by Dr. Goldspoon. For the first time in 1914, he reported a successful correction of menstruation after wedge resection of the polycystic ovary. And this is his article. If you read here, surgical treatment consisting of wedge resection of the cystic cortex of the ovaries, and was successfully in completing and restoring physiological function. Menstruation اتحسنت، لكن هنا وقال برضو ان some patients achieve pregnancy. ده كان أول منشأ. الحقيقة العملية دي اللي هي bilateral wedge resection was very popular. يمكن اللي سنهم كبير شويه دكتور ابو بكر النشار والجيل بتاعنا ويريمبر كان في اوبراتيف ليست كامله في المستشفيات تقشير مبايض bilateral wedge resection. وطبعا later on we realized it was not a good option because of the development of adhesions and complication. Introduction of endoscopy brought another window. The first reported description to use laparoscopic surgery for PCO by Rahul Palme. I didn't see him personally, but I worked with his student. تلميذه اسمه مسيو دوبيسون في اوبيتال بورويل. انا اشتغلت مع دوبيسون and دوبيسون حكالي، انا عايز اسلكوا القصه، حكالي فكره the idea how Rahul Palme did laparoscopic surgery for PCO. رغم ان الليترشر بيقول ان هو اول واحد عمليه البي سي او، actually Rahul Palme was not intending to treat polycystic ovary by laparoscopy. He was the first in France to introduce diagnostic laparoscopy. ولما شاف when he saw this polycystic ovaries, he was confused. He didn't know what is the pathology. So he designed what he called Palme punch forceps. It was a big forceps to take a punch biopsy from the ovary. أنا القصة دي مهمة جدا عشان تعرف إزاي الصدف how circumstances and coincidences. هو كان عايز ياخد بايوبسي من الأوفري عشان يحلله histopathology ويعرف what is the problem. But fortunately بعد ما عمل العضة دي في الأوفري لقى الستات دول they improved والدورة اتحسنت وفي منهم reported pregnancy. فبدأت فكرة إن احنا نعمل laparoscopic approach. فتاني بقول لك إن راهول بالمي الكلام ده في الستينات سنة 67 قبل موضة اللاباراسكوبي كان بيعمل بس بانش بايوبسي من حالات البوليسيستيك اوفري ولاحظ إن هي حصل لها حمل. ولكن أول برضو mentioning in the English literature for laparoscopy كان by Dr. Robert Neuwirth من Columbia University School of Medicine. دكتور أبو بكر النشار دايما يحب الإيفيدنس ويقول لك اديني إيفيدنس. لو أنا قلت إن أنا كنت صاحب الفكرة ما حدش هيصدقني. هو ده روبرت نويورث صورته معايا. روبرت نويورث انا اتعرفت بيه وقلت له الفكره وهو اللي نشرها الحقيقه. فادي صورتين ليا مع روبرت نويورث وكان اول من عمل فكره اللابارسكوبيك ابروتش. لكن اول واحد نشرها بقى كان دكتور هالفارد خوانيز ده من اوسلو من النرويج. سنة 1984 كان the first published laparoscopic ovarian electrocauterization او المشهورة باسم تثقيب المبايض electrocautery او ovarian delivery. تمام؟ الحقيقة يا دكتور بكر بص معايا كده، الراجل ده من النرويج ونشرها في احسن مجلة، والريزلتس بتاعته ovulation rate 92% وبريجننسي ريت 80%. ما تحبش تقول حاجه؟
تحب طبعا.
لا ما هتقول ما انا بقى هقطع هدومي من اللي كله حد يقول لك ايه الراجل ده، يعني انا اي دونت بليف ده. طب الكلام واسع قوي يعني، واللي ما يعرفش يقول عدس او الراجل ده قال. فكانت النتيجه يا دكتور ابو بكر ان خلق الله في العالم كلهم دخلوا بالمنظار يخرموا المبايض. تمام؟ يخرموا المبايض واكستنسيف يوز اوف الكتروكوتري. الحقيقه العبد لله في اواخر التسعينات I developed a technique for ovarian drilling. ده هنهي بيه بقى واقول لكم اللي عايز يعمل ovarian drilling اللي عايز يعملها بالطريقه دي، ولو ان خلاص دلوقتي most of the indications can be most of PCO can be cured by induction. لكن this technique انا الحقيقه نشرته في امريكا، والشريطه دي ان هم الامريكان سوسايتي اوف ريبرودكتيف سيرجن ادوني جايزه عليها، سميته سبيكوس. خلينا اشرح لكم ايه هو السبيكوس دي، الحاجه اللي عايزكم بقى. انا خلصت كلام في التاريخ، هنتكلم بقى علم. الاوفيريان دريلينج هو عباره عن مالتيبل بانكشر للاوفري، كل بانكشر بتحرق حته كوترايز بارت اوف ذا ستروما، فيحصل ويدج اوف سترومال ابليشن. يعني بدل ما تعمل انت عمليه وتقطع ويدج وتشيله من المبيض بالجراحه التقليديه، لا. المشكله في البوليسيستيك اوفري ان الاستروما دي بتفرز اندروجين زياده، فلو شلنا حته من الاستروما بنصلح الهرمونال ديستربنس وبتنتظم الدواء وبينتظم التمويل. ولكن الويدج ريسكشن دي عمليه جراحيه وفتح بطن وممكن تاخد غرز، ممكن يحصل بعدها اديشن. The laparoscopic approach by the Norwegian doctor اللي هو دكتور خوانيز هو عباره عن multiple puncture بتتخرم في المبيض 10 تخرام او 4 تخرام. Every puncture cauterize a small part of the stroma and eventually بتنتهي بويدج ablation. ولكن برضو المالتيبل بانكشر بتعمل سيرفيس تروما، والسيرفيس تروما دي might invite adhesions، والاديجن دي تعمل لك تيوبال فاكتور. يبقى انت داخل تصلح اوفيريان فاكتور، تطلع بالعمليه عندها تيوبال فاكتور واديجن. ده اللي خلاني ابتكر التكنيك بتاعي. هو المفروض هنا في انيميشن بس مش هعرف اشغله. I designed a special needle وشركه كارل ستورز عملتها لي. It is a long needle and then you puncture the ovary from single puncture and you drive the needle subcortical into the stroma. بس مش شيش كباب، يعني مش بتطلع من الناحيه الثانيه، ما بتطلعش من الناحيه الثانيه. So this needle will create adding needle will create a track of stromal ablation. طب تقول لي ايه الفرق ما بين التكنيك بتاعك والتكنيك بتاع الراجل بتاع اوسلو؟ ان انا هنا عملت only single puncture. So both techniques achieve the same purpose of stromal ablation، بس الفرق بدل ما تعمل 4 أو 10 تخرام عملنا خرم واحد. الحقيقه انا شايف ان التكنيك ده اقل ضررا من غيره، والايفيدنس بتاع دكتور ابو بكر قدامك اهو. فين دكتور ابو بكر؟ الراجل ده اسمه ايه؟ الراجل ده اللي خد جائزة نوبل اللي هو بوب ادواردز، اللي هو اول
الله
واحد
يرحمه يا اسامه.
الله يرحمه. تمام؟ دي امضته يا دكتور ابو بكر، دي امضته. وكاتب لي دكتور شوقي one of our editors highly recommended ان البيبر بتاعتك عن البي سي او would make an excellent paper for human reproduction. والراجل ترجاني ان انا انشرها، وانا عملت ايه في الاخر؟ ما نشرتهاش. بوب ادواردز قال، ده رأي الراجل رأي محترم جدا، قال I am totally against ovarian drilling. قالها بصراحة، لأن ده ممكن يأذي المبيض ويعمل ovarian failure. قال ولكن لو في إنسان في العالم ما زال عايز يعمل ovarian drilling يعملها بطريقة الدكتور المصري اللي هي الليست. والحقيقة أنا قدمت الكلام ده بره، الابيوز اوف اوفيريان دريلينج طبعا ده اوفيريان باربيكيو. انا بحذر الزملاء، بشوف بعض ناس يخش بالمنظار ويتعامل مع المبيض زي العروسه بتاعت الحسد، يفضل يخرم فيه ويحرق فيه فاكرها ان دي شطاره. No, this will end with ovarian failure. فكره التعامل مع المبيض سيرجيكالي لقت وسيله ثانيه، تكنيك ثاني اسمه توش. دكتور ابو بكر اللي
ايوه
عامل التوش ده صديقك، عارف صديقك مين؟
ايوه
دكتور عبد المجيد رمزي.
ايوه.
الكلام ده كان سنه 2008 ومنشوره فين؟ منشوره
مم.
في الاكتا اسكندنافيا، منشوره في مجله محترمه جدا. الترا ساوند جايدد اوفيريان ستروما هيدروكواجيليشن. هنا الدكتور عبد المجيد قال بدل ما اكوي المبيض بيحقن فيه ميه سخنه. فانا كنت بهزر معاه وبتريق عليه وقلت له دي اسمها سلق المبايض، يعني بيسلقوا المبيض بيحقنوا فيه ميه سخنه. الكلام ده من 2008، لكن 2003 كنت انا قدمت برضو ترانس فاجينال الترا ساوند جايدد الكتروكوتري. الكلام ده في 2003 يا دكتور ابو بكر.
ايوه
وطبعا لاقت رفض شديد وقالوا ملهاش اي داعي وبطل الكلام بتاعك ده. دي اتنشرت في امريكا في انديانا، ودي زميلتي في البحث دكتوره ريتا من جامعه بيلر. ترانس فاجينال الترا ساوند جايدد اوفيريان كوتري. الحقيقه شكلها يعني خض، لكن اللي انهي بيه كلامي بقى اقول لك ان في 2023 يا دكتور ابو بكر 2023 في فيرتيليتي اند ستيريليتي في ارتكل منشوره تخض جدا، ترانس فاجينال اوفيريان دريلينج قبل الاي في اف. شوف بقى الكلام، يعني انت بتقول بي سي او دي تخش تعمل دي فيرتيليتي اند ستيريليتي، مش مجله الكواكب ولا مجله الموعد، تمام؟ فيرتيليتي اند ستيريليتي. والارتكل منشوره في امريكا ان ترانس فاجينال اوفيريان دريلينج قبل الاي في اف بيحسن النتائج جدا. وقالوا تي في او دي ترانس فاجينال اوفيريان دريلينج اسوشيتد 7 اضعاف انكريز ان ايوبلوي بلاستوسيست، وبيقلل قوي الانوبلوي بلاستوسيست، فبيحسن نتائج الاي في اف. هل انا اسامه شاوي مقتنع بالكلام ده؟ انا بحكي لكم وبس، بحكي لكم العالم بيفكر ازاي الايفوليوشن بتاع تفكير العقل البشري. واذا كنا عايزين اولادنا ودكاترتنا يبقوا شاطرين يبقى نعلمهم ازاي يفكروا، مش نعلمهم ازاي يسمعوا ويقروا. بعد السنه الجايه لما نتقابل هنتكلم على البي سي او ونقول ايه؟ انا ما اعرفش، لسه المستقبل بيخفي الكثير. ولكن قبل ما اسيبكم اتمنى اكون قدمت لكم entertaining educational motivational talk. Thank you وبحبكم
Thanks a
كلكم.
lot, Professor Osama, the king of hysteroscopy and as he mentioned entertainment. الحقيقة يعني as usual very interesting and يعني go to the history, to the science and everything is clear. And also if we have any questions for Dr. Osama or any comment.
قبل الكويشن يا دكتور ابو بكر، نصيحه للاخوه، اذا كان المؤتمر ده عايزين نطلع بمعلومه واحده، بلاش تثقيب المبايض، بلاش كل واحده بي سي
يا
او
دكتور
تجيلنا.
أسامة, we will address this according to the last guideline and we will mention why it is declining and there is restricted indications for laparoscopic ovarian drilling.
اونلي بس عشان نكون صادقين، اللي ساكنين في حتت بعيده في
بالضبط كده،
القرى في
يعني احنا
الصحراء.
هنقول ايه الانديكيشن بتاعه nowadays. لكن
بالظبط.
هو ايام زمان in the past they mentioned that if there is a failure of clomiphene or letrozole or gonadotropin, we will go either to gonadotropin or to the laparoscopic ovarian drilling. But according to the evidence nowadays, no, the recommended is the gonadotropin stimulation, not laparoscopic ovarian
دكتور
drilling.
ابو بكر تسمح لي بدقيقه واحده بس اقول حاجه، قصه حلوه قوي.
اتفضل يا
دقيقه
دكتور.
واحده بس.
اتفضل.
هقولها بالعربي. لما
اتفضل.
عملت when I invented my technique for ovarian drilling والنيدل I was a lecturer، كنت مدرس في القصر العيني. فكان عندنا حكيمه نيرس في اوضه العمليات، she was very obese short head hirsutism 11 years infertility typical PCO. فاستاذي الدكتور ضياء سرحان قال لي ما تيجي يا واد يا اسامه نجرب نعمل للحكيمه دي العمليه دريلنج بالتكنيك بتاعك. اسمع القصه دي واضحك عليها، قصه غريبه جدا. دخلنا اوضه العمليات، العيانه كانت تخينه جدا، فهو قال لي let me do it. He inserted the trocar and then introduced my needle. النيدل is very long. واخد بالك دكتور ابو بكر؟
ايوه
فالنيدل ما دخلتش through the trocar تماما.
ايوه
فكانت ملمسه مع التروكر. فجينا نقرب من المبيض، اول ما عملنا اكتيفيشن للكهرباء التروكر نفسه كان ملمس. العضلات انقبضت، العينه اتنفضت على ترابيزه العمليات، اتخضينا ما عملناش حاجه. ما عملناش دريلينج، اتخضينا ما عملناش دريلينج.
ايوه
اقسم برب العظيم العينه دي بعد 3 اشهر حملت. والقصه دي اللي كتبها محمد عبد القدوس ابن احسان عبد القدوس واتنشرت في مجله. فحكايه الكهرباء واللسع دي سر ما
بس
حدش
معلش يا دكتور اسامه، we cannot depend on a single case. We are in the era of evidence-based medicine and we should have a proof for all of this. Thanks, Professor Osama, and we'll shift to the next speaker. I am the next speaker. Without any introduction, I will go to what is the evidence-based management of the PCOS associated infertility. شكرا دكتور أسامة شوقي.
شكرا واشوفكم على خير ان شاء الله.
اشوفك على خير ان شاء الله دكتور أسامة. I will go to
تسمح لنا بتعليق بس يا دكتور؟
يا اهلا وسهلا بالدكتور غازي ابراهيم. حضرتك في
أسامة
العراق ولا في الاردن يا دكتور غازي؟
في الاردن. ويل دان
منوره.
ويل دان أسامة. سلام وتحية لأعز اثنين، أسامة وأبو بكر في أم الدنيا مصر
انا اللي
الحبيب.
سعيد بان انا اسمع صوتك يا دكتور غازي
من
والله.
الأردن الوفاق والاتفاق.
الله
بس
يخليك.
التعليق بقول له
اتفضل.
don't worry أسامة, we change the name and not what we do. This is the end result with PCOS. Thank you.
So you are with or against the change of the name, Dr. Ghazi?
No. The change of the name will not change what we do.
Yes, there is only a good description of the pathology. And from the old, it was mentioned that the PCOS syndrome is the ovarian manifestation of the metabolic syndrome. It was mentioned like that. And I think this is now the application of this statement. I am happy with the change of the name, and there is no change in the diagnosis and no change in the management. So we will go direct to the share screen. Yes, where is it? Yes, the slides are okay?
Yes.
Yes. So I will address evidence-based management of PCOS associated infertility. Just to invite you to have my books available in the market. One book in colposcopy, another in ovarian stimulation and IUI, another one in fertility, and another one in IVF, and lastly in obstetric. So we mentioned that and evidence-based. This is the pyramid of evidence. And as we see here, at the top of this pyramid, the clinical practice guideline. So we will concentrate only. Our sources of this lecture is the clinical practice guideline. Like what? Like the international evidence-based guideline in 2023, like the WHO guideline in the 2025, and the very recent one, the NICE guideline in 2026. Just to have what is why the PCOS syndrome is associated with infertility. This may be attributed to, number one, chronic oligo or anovulation. Number two, hyperandrogenism. Number three, the insulin resistance and hyperinsulinemia, the obesity-related endocrine dysfunction, and lastly, the alteration in endometrial receptivity. I will not go to the details because it is mentioned by Dr. Amina about how to diagnose. It is mentioned we have steps, but actually in our locality or in our region in Egypt, we are depending first on the ultrasound. But in Europe, they are depending first on the history, if we have irregular cycle and clinical hyperandrogenism, that's to say if there is alopecia, if there is hirsutism, it is enough for diagnosis of polycystic ovary syndrome and after exclusion of the causes. But if there is no clinical hyperandrogenism, they are depending on Europe on the lab, the biochemical hyperandrogenism, and if it is biochemical hyperandrogenism plus irregular cycle, it is polycystic ovary syndrome. And lastly, because not every gynecologist is doing ultrasound, and you should refer the patient to do ultrasound. So it is the last, but this is not the usual scenario in Egypt or in our countries. And this mentioned by Dr. Amna, how we have 4 different phenotypes of polycystic ovary syndrome. I will not go to the details, and this is the Rotterdam criteria, anovulation, hyperandrogenism, and the polycystic ovary by ultrasound. I will go direct to the management, and we should start the management in the preconceptional period. How? Number 1, counseling. Counseling is very important. We should inform our patient about how the obese, how the overweight will affect the pregnancy, how it will affect the miscarriage, how it will affect the live birth rate, and the importance of losing weight as a first step in the management of polycystic ovary syndrome associated infertility. Then the second step in the preconceptional care is evaluation. Evaluation, we should do the basic infertility steps or investigation. Semen analysis. Are we going to do the tubal patency as a routine? The answer, no. And according to the guidelines, it should be individualized based on what is the risk, what is the benefit, what's the cost, what's the technique, and what is the personal history, and what is the prevalence of the tubal disease in our locality. The third is to assess the ovulatory status. And as we mentioned, we have 4 phenotypes of polycystic ovary syndrome. And one of this type, which is type 3, which ovulatory polycystic ovary syndrome. Then to assess the body mass index and to assess the blood pressure, and according to the guidelines. And some are not doing this, but it is a strong recommendation to ask for oral glucose tolerance test for any woman with polycystic ovary syndrome planning a pregnancy or seeking fertility treatment. And then the thyroid function, the TSH and the prolactin is only indicated according to the guideline if there is a suspicion of this. But for me, I am doing the TSH for all the infertile patient, and only the prolactin if there is any ovarian dysfunction, if there is any suspicion, if there is galactorrhea or suspicion of the pituitary adenoma. But not only this, and this was mentioned by Dr. Amna, the mental and the emotional condition and sexual health should be evaluated. So these are the evaluation: basic infertility, body mass index and the blood pressure, oral glucose tolerance test, thyroid function and the prolactin if indicated, and to assess the mental, the emotional, and sexual health. And we should avoid the unnecessary testing. Endometrial microbiome is not indicated. Routine fasting insulin is not indicated. And again, I am sticking to the guideline. Folate supplementation is recommended. What is the dose? The usual dose is 400 microgram. But if our patient is obese, we should give the 1000 or the 1 milligram daily, and we should start before pregnancy. And lastly, if there is diabetes, it should be treated. Hypertension to be treated. If the patient is anxious, depressed, or there is mental health, it should be treated. So we will go to the guideline, as I mentioned, and this is the ISHRI guideline. And there is Dr. Osama Shawqi, if you are with us, quite a change. What is in the blue is what's recommended, and what is in green, it is alternative. And we should start by optimizing the preconceptional, as I mentioned, and the lifestyle modification. And the first medical treatment is letrozole. But the alternative is clomiphene citrate plus metformin. If there is no ovulation, the recommended is gonadotropin, but we should do ultrasound monitoring and we should adjust the dose, and we will address all of this. And the alternative is laparoscopic ovarian drilling. And the laparoscopic ovarian drilling, as I mentioned, there is restricted indication. And if there is no ovulation, the third line medical treatment is IVF. So IVF is not a first line treatment, is not a second line treatment, but it is a third line treatment for polycystic ovary syndrome. Let us go to the recent one. The WHO, they say also it is what is recommended in the green, and what is the alternative is in the blue. And the first is lifestyle modification, letrozole, gonadotropin, not the laparoscopic ovarian drilling, and lastly the IVF. Let us start and to go in this in details. So we have 3 steps. The lifestyle intervention for all women with polycystic ovary syndrome: healthy eating, regular physical activity, healthy lifestyle behavior. And our objective is weight reduction. It is enough to have a weight reduction 5% to 10%, because this will be reflected on a significant improvement on the ovulation. And please, you should give a time for this. 6 months is enough. The second is to stop smoking and to stop alcohol. All of this have a deleterious effect on the outcome. The dietary intervention, as we mentioned, healthy eating principles, and no diet type is recommended. What is mentioned by some companies, there is a special diet for PCO, is not recommended, is not correct, but this is only a commercial thing, and no one dietary type recommended in the PMOS. And to go to some details, we want to achieve weight loss. How? By to energy deficit 30% or 500 to 750 kilocalorie per day. The second is exercise. Exercise in adults is recommended 150 minutes per week of moderate intensity physical activity. And the anti-obesity medication. Let us, as we mentioned, to go to what is the guideline. The ISHRI mentioned that the anti-obesity medication is recommended only in research setting, and it can be considered with lifestyle. And our indication of the anti-obesity, if there is failure to lose 10% of weight, we mentioned 6 months. Despite the lifestyle changes, we can give the anti-obesity according to the guideline, but of course we should consider the cost, the contraindication, and side effect. What is available? The orlistat, which is the first drug approved by the FDA, and the dose of the orlistat 120 milligrams 3 times daily with meals. What's about the new? The glucagon-like peptide 1 receptor agonist. Let us go to the last systematic review and the meta-analysis in 2026. There is a modest short-term weight loss, 9% weight loss, and 71 maintained at 3 years. The use of the glucagon-like peptide 1 receptor agonist will reduce the progression to diabetes by 80%. But what is more important in this systematic review, the evidence for benefits on the metabolic, on the reproductive, on psychological outcome remains uncertain. Why? Due to the low quality data. We are talking about the use of the GLP-1 receptor agonist in polycystic ovary syndrome associated infertility. And there is no studies have evaluated the cost effectiveness. It is expensive, and we should consider the cost effectiveness of this drug. And the most important is we should stop the use 1 to 2 months before pregnancy. So this is regarding the glucagon-like peptide 1 receptor agonist. Let us go to the bariatric surgery. Bariatric surgery is the third line treatment option. We are talking how to reduce the weight. And according to the NICE, it is old. The NICE guideline in 2013, we have certain indications for bariatric surgery in the polycystic ovary syndrome. Number one, if we have a morbid obesity, that's to say the body mass index is more than 40, and there is a failure to lose weight by the other means. Number two, if we have moderate obesity, that's to say the body mass index is more than 35, but there is a comorbidity. Patient is hypertensive. The patient is diabetic. And let us go to the ISHRI in 2023. It changed the recommendation. The bariatric surgery in polycystic ovary syndrome should be considered experimental. You see, so the evidence-based guidelines are not static, it are dynamic according to the available evidence. Let us go, so this regarding the first step, which is the lifestyle modification. What is about the second step? The second step is induction of ovulation. And letrozole, as I mentioned, is the first line treatment for induction of ovulation, and the pregnancy should be excluded. Before giving letrozole, we should exclude pregnancy. And we know the dose 2.5, the maximum dose is 7.5 milligram for 5 days, starting from day 2, day 3, or day 5. The second is metformin, and metformin can be used, but the others are more effective than metformin. The letrozole, more effective. The clomiphene citrate is more effective. And we should keep in mind the mild gastrointestinal upset associated with metformin. Then the clomiphene citrate, it is better than the metformin, and the risk of multiple pregnancy is increased with clomiphene citrate, and that's why cycles may be require ultrasound monitoring, and combination with metformin could be used, as we mentioned, according to the guideline, rather than clomiphene citrate alone, and the combination with metformin could be used rather than metformin alone. And there is no difference, because there was a concern about the fetal malformation associated with letrozole. Nothing, it was not proved. And there is a recent study in 2025, the combination of letrozole with clomiphene, and found that they will be reflected on improvement of the ovulation rate, pregnancy rate, and hormonal levels of the PCOS. What's about the myoinositol? And again, I will stick to the guideline. According to the guideline in 2023, myoinositol should be considered experimental. Why? This is according to the guideline. The benefits and the risk are contrary too uncertain. There is limited evidence with uncertain results. The side effects and safety are not known for inositol. And the recent guideline of the ISHRI in 2025, myoinositol in PCOS is not recommended. Let us go to we are talking about the second step. The second step is induction of ovulation. We discussed the letrozole, clomiphene citrate, metformin, and the myoinositol. What's about the gonadotropin? The gonadotropin alone is recommended. It could be considered rather than clomiphene citrate, and it is should be considered rather than combination of clomiphene citrate and metformin. and also it should be considered rather than gonadotropin combined with clomiphene citrate. So those who are giving a combination of clomiphene citrate and the gonadotropin to decrease the cost, we should tell them the outcome is less than the use of gonadotropin alone. It may be a second line therapy for women who fail the first line oral ovulation, either letrozole or clomiphene citrate plus metformin. And as we mentioned in the past, either laparoscopic ovarian drilling or gonadotropin, but nowadays the recommended is the gonadotropin. And why? Because it was found that there is a higher live birth rate, but on the other hand, higher multiple pregnancy with gonadotropin than with the laparoscopic ovarian drilling. And that's why the starting dose of the gonadotropin should be not more than 150. We can start it even with half vial. And we have 3 regimen of the gonadotropin. The recommended in the polycystic ovary syndrome is the chronic low dose step up protocol. We should avoid the multiple pregnancy by cancellation of the cycle if we have more than 2 follicles with a diameter more than 14 millimeter. And in this condition, we should avoid also the unprotected intercourse, because spontaneous ovulation can occur and multiple pregnancy can not prevent it in this condition. Let us go to the laparoscopic ovarian drilling. Laparoscopic ovarian drilling could be a second line, and the indication, the patient should be anovulatory. We cannot use it in the ovulatory polycystic ovary syndrome and infertile. There is resistance to clomiphene citrate or letrozole. We should not have any other infertility factor. And it may be preferred, as mentioned by Dr. Osama, if the monitoring is difficult, because for gonadotropin, we should ultrasound monitoring is mandatory. And also it is recommended when the multiple pregnancy risk is a major concern. One patient suffering from cervical incompetence, and if she is pregnant in multiple pregnancy, the loss of the baby will be high. And in this condition, laparoscopic ovarian drilling may be preferred. And also laparoscopy is indicated for another reason. We have another reason to do laparoscopy, so we will do laparoscopic ovarian drilling because of the other cause. And when using laparoscopic ovarian drilling, the cost is important. We should compare the cost of ovulation induction. And also we should put in consideration the expertise of the surgeon, it is present or not. And the intraoperative and the postoperative risk, the most important are the adhesion, which are higher in women who are above healthy weight. The third line of treatment, which is IVF, and what is the indication? If we have additional infertility factors, and we mentioned this before. Number 2, advanced maternal age. One patient and her age is above 37. And if we have an absolute indication for IVF or ICSI, so like the male factor. So we should consider not only one factor, but all the other factors. The tubal factor should be considered, the male factor should be considered, presence of absence of endometriosis should be considered, and also, again, as I mentioned, it is not a first or second line, but it is a third line for treatment of infertility associated polycystic ovary syndrome. The IVF is effective, and it is recommended to do elective single embryo transfer. And in this condition, we will avoid the multiple pregnancy. Counseling is very important, and we should tell the patient about the increased risk of ovarian hyperstimulation syndrome and what are the methods to reduce this risk. We will discuss, inshallah. The choice of the FSH either urinary or recombinant, it can be used. And for the protocol, the recommended protocol is the antagonist protocol. Why? Because use of we can use the agonist for the triggering, and this will decrease the incidence of ovarian hyperstimulation syndrome. But in this condition, most of the doctors prefer to freeze all, and with the antagonist protocol, the risk of the ovarian hyperstimulation syndrome is much more reduced. Another protocol, which is the PCOS, the progesterone primed ovarian stimulation. It is can be recommended, and in this protocol, we will give the medroxyprogesterone acetate or the utrogestan. We will start from day 3 with the HMG, and then we will do trigger. But in this condition, freeze all is recommended. We cannot do fresh embryo transfer. And it was found that this PCOS protocol will decrease the incidence of ovarian hyperstimulation syndrome, and the fertilization rate, the clinical pregnancy rate, and the implantation rate are significantly higher. What's about the use of the adjuvant? For the use of adjuvant, metformin is not recommended in the antagonist protocol. But if some still using the agonist protocol in polycystic syndrome, and this is not recommended, but in this condition, they should use the metformin to decrease the incidence of ovarian hyperstimulation syndrome. We should commence at the start of the agonist for the use of the metformin, so it is only indicated in the agonist protocol, and gradually increase the dose of the metformin because it's associated with gastrointestinal upset. The prevention of ovarian hyperstimulation syndrome is very important in the polycystic syndrome, and again, it's recommended at the beginning to assess the risk, and then to the antagonist protocol, to start with a small dose of FSH, to trigger with the agonist, and it's recommended also for embryo transfer, single embryo transfer. All of this will decrease the incidence of ovarian hyperstimulation syndrome. Freeze all strategy is recommended to minimize the risk of late onset ovarian hyperstimulation syndrome. We have two types of ovarian hyperstimulation syndrome. We have the early onset and the late onset ovarian hyperstimulation syndrome. And as I mentioned, the agonist trigger and the freeze all will decrease the incidence of ovarian hyperstimulation syndrome. The use of the dopamine agonist, the cabergoline, particularly if I am triggering with HCG, is recommended to decrease the risk of ovarian hyperstimulation syndrome. But again, according to the guideline, it is not recommended to use the dual trigger in high responder. That's to say, to trigger with the agonist and HCG, it is not recommended. The in vitro maturation, according to the guideline, the in vitro maturation XZ is less effective than the standard IVF XZ in terms of clinical pregnancy rate and live birth rate. In vitro maturation can be offered if there is a history of severe ovarian hyperstimulation syndrome, and also it can be offered where the risk of severe ovarian hyperstimulation syndrome is unacceptable high, and if we have, but we should have a sufficient expertise if in the in vitro maturation in this condition. So to come to the conclusion or the evidence-based take-home message. Number one, lifestyle intervention is fundamental. Number two, letrozole is the first line ovulation induction agent. Number three, metformin is important adjuvant in selected women, only in the agonist protocol, which is not recommended in the polycystic ovary syndrome. Gonadotropin and laparoscopic ovarian drilling are second line option, but gonadotropin is recommended and laparoscopic ovarian drilling is alternative. IVF is highly effective when earlier steps fail, and it is a third line of treatment of PCOS syndrome. Ovarian hyperstimulation syndrome prevention is critical in IVF cycles. And lastly, this is my books, and I would like to thank all of you. If there is any questions, I am happy to listen to it.
السلام عليكم.
اسم حضرتك؟
Good evening, professors and doctors
Good
all
evening.
around
What's
the
your
world.
name?
My name is Dr. Beskri, and I'm obstetrician and gynecologist in Libya.
Libya, welcome.
It's
Yes.
truly an honor to join this discussion.
Yes, please.
From my perspective, the shift from PCO to PMOS appears to be more terminology refinement than a fundamental change in the concept itself.
No, there is no change in the management or in the diagnosis. Just it is an accurate description of the pathology. If there is any other questions or comments, Professor أسامة شوقي. يس دكتورة سدرة الشيخ، اتفضلي يا
ايوه
دكتورة.
دكتور، بشكر حضرتك كتير على المحاضره الجميله دي، بس انا ليه سؤال بس عايزه اعرف.
انت اللي جميله يا دكتوره سدرة، انت اللي جميله والله، اسمك جميل
ربنا
قوي،
يخلي حضرتك.
سدرة المنتهى.
ربنا يخليك. ايوه
اتفضلي.
شكرا يا دكتور جدا. يعني انا بسال حضرتك الاي اي ايه دوره في يعني دوره بس في الدايجنوزيس مثلا؟ يعني حضرتك اتكلمت
لا،
على الاي
دوره في
اي في
كل حاجه يا دكتوره، دوره في الدايجنوزس،
يعني
دوره في
احنا في
البريدكشن اوف
ابلكيشن معين
ذا
مثلا.
كومبليكيشن. لا دقيقه واحده. وكمان دوره في البريدكشن اوف ذا اوت كام، لكن زي ما قلنا لسه ما هوش وايدلي سبريد، واضح. هو كوستي، ولذلك يعني ما نقدرش نقيمه على دلوقتي. وزي ما الدكتوره جمانه قالت ان في له دروباكس، ويمكن الدكتور محمد سلامه جاد كان اتكلم عن هذا في احد المؤتمرات. اي سؤال اخر؟ ما شاء الله، محاضره ممتعه جدا. ما اعرفش هي بتقصد مين، لكن هنقرا برضو الشات اللي مكتوب في الشات، واذا ما كانش كده في كومنت سيكشنز. حاضر، هنشوف اللي في الكومنت سيكشن. بسم الله الرحمن الرحيم. شات اهو. كل الشكر لشركة نرهادو. ممكن لينك التسجيل. موفقة دكتورة أمنة. ايه كمان في الشات؟ عايزين أسئلة. Special thanks to Servier for great effort and continuous support, valuable lectures. وهنا في دكتورة إمام بتقول احنا ممكن ان احنا يعني to maintain the same terminology. I think it will take time to use. يعني احنا كنا واخدين على اسم البي سي او اس بنقوله كده من غير تفكير، لكن هتاخد فترة لغاية ان احنا to shift to the new terminology. في ايه كمان؟ في طبعا في ناس بيقترحوا اسماء اخرى، لكن انا عايز اقول بان هم وصلوا هذا الاسم بعد يعني مباحثات وبعد مجادلات طويله علشان يوصلوا لهذا. في ممكن جدول المحاضرات. طيب لو سمحتوا ابعتوا لهم جدول المحاضرات، ومتشكرين جدا. وايه من سيرت من ليبيا، والدكتورة كريمة شكرا. واعتقد بان دي كل اللي موجود. لا ده في حاجات تانية كمان اهي. شكرا دكتور ابو بكر، جزاك الله خيرا. واللي في كمان multidisciplinary approach is recommended طبعا بالتأكيد. ايه كمان؟ منور دكتور أسامة. دكتور أسامة كل ده منور، وأعتقد بأن ده كل ده عبارة عن شكر. أنا في دكتور محمد منير بيقول as a computer science specialist and data analyst we will try to provide lower prices for AI models. ده شيء عظيم جدا. شكرا انجينير محمد منير. to AIDS diagnosis and prediction. طبعا ده اللي بنأمله دكتور باشمهندس محمد منير. في دكتورة فاطمة بتقول I asked myself if changing the name added any benefit to diagnosis. لا، ولا diagnosis ولا treatment، لكن قلنا عبارة عن accurate description of the pathology. بعد كده very good إيرا. وبعد كده في ناس بتشكر، ودكتورة تقى بتقول أنا سعيدة بانضمامي لكم وبارك الله فيكم. الحقيقة أنا كده يعني في ختام هذه السيشن اللي كانت very fruitful. بشكر كل السادة. I would like to thank all the speaker and also I would like to thank the American Association for Continuous Medical Education. I would like to thank all of you اللي انتوا اشتركتوا معانا. we will come to break. البريك هيكون 5 minutes، وبعد كده the moderator will be Professor محمد سلامة جاد, Professor of Obstetrics and Gynecology منوفية University after 5 minutes of break. شكرا لحضراتكم ونراكم على خير إن شاء الله.
We are back again. Who we are? We are AAGC. And the numbers will speak up. Millions of women around the world regain their confidence, comfort, and quality of life. Through the power of aesthetic gynecology, a specialty that goes far beyond beauty, it's not a luxury, it's healthcare. Behind this impact, over 8,000 trained doctors, 450 certified training programs, and 35 major scientific conferences. We pioneer bringing that exact same unmatched leadership to the entire spectrum of women's health. Introducing 4 mega conferences under one roof: the Aesthetic Gynecology Conference, the Gynecology Endoscopy Conference, the Pregnancy and Beyond Conference, and the Infertility and IVF Conference. 4 conferences, 1 platform, infinite impact. We are bringing together the pioneers shaping the future in the Middle East. July 16th to 17th at Hilton Cairo Grand Nile. Register now to be part of the movement. We are back again. Who we are? We are AAGC.
Modern patients are no longer searching for temporary solutions. They are looking for true restoration. They want science-driven transformation. Today, this field goes far beyond traditional cosmetic procedures. The future is built on cellular renewal, advanced biostimulation, and evidence-based regenerative medicine. Because patients today expect more than routine treatment, learn the protocols shaping the future of women's intimate wellness. Not by watching, not by theory alone, but by practicing every technique yourself. Learn patient assessment, diagnosis, treatment planning, and procedural precisions. Learn the latest injectable protocols, tissue restoration strategies, and modern regenerative alternatives. Because expertise means knowing how to explain science clearly and guide patient decisions. Deliver outcomes your patients are truly looking for. This is where doctors become future leaders. Registration is now open. At American Association, IVF education means learning what top fertility experts actually do, understand the full science behind ICSI, and when it truly improves outcomes, learn modern stimulation strategies, trigger personalization, freeze all decisions, and AI-based embryo selection updates. Here, every doctor manages one case from diagnosis to protocol planning and fertilization strategy. Learn exactly when to shift protocols, optimize ovarian response, and make evidence-based treatment changes. Because great IVF doctors know how to convince patients through trust, clarity, and science. Master clinician embryologist collaboration and make better treatment decisions. Poor responders, implantation failure, severe male factor, advanced decision making. This is where IVF doctors become clinical decision makers. Your next level starts here. Registration is now open.
The journey started in 2020 with one clear mission: to support doctors through continuous medical education based on real practice and hands-on experience. What began as a conference in aesthetic gynecology has grown into a comprehensive scientific platform bringing together multiple gynecology specialties. Last year, we delivered 42 lectures in aesthetic gynecology, 36 lectures in IVF and infertility, 28 lectures in OB/GYN endoscopy, with 120 plus international speakers from around the world. Now the journey continues at the 7th Annual AAGC Conference.
دكتور محمد سلامة.
الو.
اتفضل يا فندم.
مفيش صورة، الشير ماي فوتو مش موجودة على الشاشة. ايوه، لسه حضرتك تفتحيها. ستيل كلوز الفوتو الفيديو. محمد سلامة. Yes, I am waiting. I am waiting.
خلاص دكتور you can proceed. واضح ان حضرتك قافل الكاميرا من عند حضرتك، فممكن حضرتك
بسم الله الرحمن الرحيم. I am so happy to share in this distinguished hub about one item, polycystic ovarian syndrome. In our program, there still be 4 titles or 4 lectures by distinguished speaker, and I am happy to congratulate American Association for this happy meeting. Our first speaker will be Professor Bentalis Constantolax. He will address us about PCOS in the era of practice precise medicine. PCOS in the era of precise medicine. You are most welcome, Professor Bentalis. Yes,
hello,
sir.
everybody. I hope you can hear me.
Yes.
Great. Thank you very much, Mohammed Salama. I mean, you said my name perfectly well, which is the hardest name of the world, I guess. But thank you so much for that. Let me try sharing my screen first of all.
Yes.
Okay.
Already seen.
Excellent. Let me make it bigger. Great. Let me just give me 1 second more. Get this out of the way. Okay, great. Well, I thank you so much, American Association for Continuous Education, and all the organizers for giving me the opportunity to take part in this really very important project. I guess after Professor El Nashar's presentation, mine is going to be boring, and it's not going to bring all this excitement that I even kept notes, to tell you the truth. Because what Professor Nashar said is the actual need of the patients, what we do, how we change things, how we prove ourselves. I'm going to talk about a more, if you want, future development, because we have entered the era of precision medicine already, and genomics and molecular signatures are going to play a crucial role in PCOS. So that's what I'm going to discuss, because I'm a geneticist, but I don't think I have actual proofs in my hands. It's just future developments that probably are going to bring future weapons. So with no more to say, these are my conflicts of interest. My name is huge, Pantelis Konstantoulakis. I am biologist in training from University of Athens in Greece. And then I did a PhD in molecular genetics in University of Washington in Seattle in US. And then a postdoc there in the University of Washington, another postdoc in NCI. And then I came back home 30 years ago, and I established the first molecular diagnosis laboratory here in Athens. I keep lecturing for the University of Athens and University of Thraiki here in Greece, and I'm directing a lab that it's called Genotipos here in Athens, and another lab in US, in Minneapolis, that it's called iLabs. So Genotipos is the biggest private molecular diagnostic center in Athens, Greece, specializing in clinical genetics, genomics, and cytogenetics, and we offer services, diagnostic services to private and public sectors. We have all the quality management you can imagine, all the ISOs, CAP, and insurances, and GDPR, and everything. And that is why we collaborate mainly with pharmaceutical companies. So enough about myself. Let's move ahead to the key aspects of PCOS in precision medicine. This, I think, is the most important slide I'm going to show you. First of all, subtype classification. There's a lot of research that emerged the last years that identify distinct PCOS subgroups based on reproductive versus metabolic characteristics. These actually subgroups can predict the outcomes of the patient. AI and data-driven tools, you've heard already from Professor El Nashar. You're going to hear again from Dr. Kumar. There's a lot of noise going on about AI and data-driven tools. Machine learning is utilized to analyze large data sets and classify the patients into these subtypes, mainly focusing in personalized measurements. This is actually the most important thing. There is a lot of emerging targeted therapies. I heard Dr. El Nashar talking about what do we do at the moment, but there's a lot of research that is focusing in novel treatments, like, for example, anti-Müllerian hormone modulation in order to restore ovulation. GLP-1 receptor agonists. Of course, you know this is the most famous drug at the last few years in order to manage obesity. NLRP3 inhibitors in order to reduce chronic inflammation, and many others. These are emerging targeted therapies that we are going to see in the next few years for PCOS patients. Molecular profiling. This is my job. So there is a lot of genomic studies going on at the moment, including mainly genome-wide association studies and also transcriptomic analysis. And all these studies have revealed distinct molecular signatures in PCOS. Particularly, you can see that in ovarian theca cells, granulosa cells, and the endometrium. So that is how you separate and you subtype the disease. It's not one disease, it's many diseases. There is a lot of heterogeneity. And finally, all these things have clinical applications. We are going to see in the next few years tailored care. For example, frozen versus fresh embryo transfer. Treatments that address the underlying mechanism, for example, insulin resistance or hyperandrogenism, and not the symptoms, what we do up to now. This is an excellent review, and I suggest to everybody to check it out. This is what I got a lot of information out from. And you see all this in detail, these treatments that are coming. These are future treatments, not only what we do at the moment, to clinical management, for example, to metabolic improvement and symptomatic suppression with metformin, COCPs. No, we are going to address the problem in root. For example, we're going to use androgen receptor agonisms. We're going to use, as I told you, GLP-1 receptor antagonisms. We're going to modify the gut microbiota or inhibit steroidogenic enzymes. All these are new tools that we are going to see in the next very, very, very few years. And in the summary of this review that I want you to take home with you is that the future PCOS pharmacotherapy lies in the integration of precision targets, the restoration of systemic homeostasis. So we move beyond the suppression of symptoms to the correction of the core mechanisms. The next generation therapeutics holds the potential to break this self-perturbating cycle of PCOS and offer the women not just temporary relief, but long-term health and, of course, fertility preservation. Let's talk a little bit about genomic and genetic markers. PCOS susceptibility is linked to several candidate genes that regulate hormone levels, metabolism, and ovarian function. Some of the genes are already known. For example, DNND1A, especially variant 2, actually, this is heavily implicated in increasing androgen biosynthesis in ovarian theca cells. Steroidogenic genes that I said before Increased expression of these genes is involved in androgen synthesis, and that is actually a hallmark of PCOS. Genes including CYP17A1, CYP11A1, and GATA6. GATA6 is a transcriptional activator of all CYP enzymes. These are critical genes that are coming into our research. And of course, metabolic and LH signaling, like insulin receptor, LH receptor, FSH receptor. These, in several studies, show significant polymorphisms and alter expression patterns in PCOS. And finally, immune-related genes. There's a lot of data that highlights higher expression of inflammatory genes like SPI1, HSPB1, MNDA, and ITGAX. So you see, these are the categories that are under research, and that's why these different subtypes of PCOS emerge. A nice review that discusses of all these genes I just mentioned, I just showed here. And of course, my presentation will be available to everybody. And this is genome-wide association studies, and that's how the new genes merge up. So if you do comparison between a PCOS patient and a patient who does not suffer, you see new genes that they come into your attention. And of course, the conclusion, which is crucial, is that inflammation, a major effector in PCOS, fuels obesity. Obesity also is an effector, and that further worsens PCOS condition. And in addition of these things, hyperandrogenism, hyperlipidemia, and insulin resistance are overexpressed in PCOS. And all this make the condition really, really hard to deal with. Which are some molecular signatures in PCOS tissues? First of all, in ovarian theca cells. We have seen lately with studies that there is specific and distinct molecular signatures that are associated with enhanced androgen production. Like 2% of the genes actually show alter expression. Genes including that they take part in Wnt signaling and retinoic acid synthesis pathways. These genes are overexpressed in PCOS patients. In oocytes and granulosa cells, there is abnormally high expression of tubulin-associated genes, specifically TUBB8, TUBA1C. This is associated actually with reduced oocyte development. And also endometrium. There's single-cell profiling that reveals alterations and spatial transcriptomics in the endometrium of obese, insulin-resistant PCOS patients with signatures that are reversible sometimes, only with lifestyle changes, and also metformin. There are also some epigenetic mechanisms one has to take in account. For example, PCOS pathogenesis involved this mechanism, this epigenetic modification, and that is what suggests gene-environment interaction. DNA methylation, a key regulatory pathway that involves the control of steroidogenesis and insulin signaling. These are altered by abnormal methylation. So sometimes we might not see mutations in genes or overexpression of genes, but we could see methylation, which methylation actually of the promoter of the gene means that the gene is not going to be able to function. Non-coding RNAs. Dysregulation in microRNAs, long non-coding RNAs, and circular RNAs play a crucial role in follicular maturation, hormone synthesis, and metabolism. And there are specific signatures that they can be found in serum, follicular fluid, and granulosa cells. And finally, M6A methylation. This is RNA methylation patterns that regulate granulosa cell proliferation and apoptosis, often linked, of course, to immune dysregulation. Let me share with you some molecular signatures, but with associated risks, something that we didn't have in mind, but we see in our patients every day. Cancer risk. We know now that there are molecular profiles that suggest that PCOS shares mechanisms, common mechanisms with endometrial and ovarian cancers, like pathways of chronic inflammation and metabolic dysfunction. And I show you here some genes, for example, with PCOS and endometrial cancer, or with PCOS and ovarian cancer. These are genes that they're modified both in PCOS and in these types of cancer. That is why we do see higher proportion of cancer in women that have suffered with PCOS. Immune and inflammatory response. PCOS is increasingly, of course, viewed as a chronic inflammatory state, and we can see elevated cytokines like TNF-A, IL-6, IL-8, etc. And machine learning. We heard that. You're going to be hear a lot about that. There is a lot of studies that have identified through machine learning diagnostic signatures, new diagnostic signatures. I'm going to share one with you. HLA-DR-A, SRM, and CTSL. These are overexpressed in granulosa cells of PCOS patients. And you can see that in this paper from this year. If you see here on the top left, this is normal controls and PCOS patients, and you can see RNA levels of HLA-DR-A on the left, of SRM in the middle, and of CSTL on the right side. This is RNA level. And on the bottom, the same genes on a protein level. So you clearly see that these are overexpressed in PCOS patients. So this is a new signature that can be used as a diagnostic tool, and why not, as a therapeutic target. If we move ahead now, I'm going to go faster through this because you heard it already. You're going to hear it again in the next talk. Digital biomarkers, wearable biosensors, new electrochemical biosensors for non-invasive real-time monitoring of hormonal levels like cortisol and androgens. This is an excellent tool for a routine diagnosis of PCOS patients. Or lifestyle and symptom tracking. Again, with digital tools, we can log menstrual cycles, diet, physical activity, and stress level. And this can help identify patterns of metabolic dysfunction, like insulin resistance or reproductive irregularities, like oligomenorrhea. AI and machine learning. You heard about it. You're going to be hearing a lot about this in the future. These are algorithms that analyze patient-reported data and wearable data like sleep patterns, physical activity, and they can predict PCOS risk. Some, as Professor Nashar said, with excellent area under the curve for detecting the condition. And finally, imaging data. He also mentioned that. AI-enabled ultrasound image analysis is already being developed to identify follicular abnormalities and ovarian structure changes that are associated with PCOS. Now, which are some key metabolic targets for digital monitoring? First of all, insulin resistance. A digital system can track markers like fasting insulin and glucose ratio and can monitor the lower insulin sensitivity that is found in PCOS. Androgen level. Monitoring hirsutism or acne via digital photo analysis and tracking free androgen index via lab data integration. This can help us identify the patients really, really early. And of course, circadian rhythms. With wearable data on sleep quality and timing, you can link this to cortisol and melatonin disruption that we see in PCOS patients. There's a lot of challenges, though, and future directions. First of all, that data heterogeneity. There's a wide variety of symptoms in PCOS. That makes consistent and reliable digital biomarker identification very, very, very difficult. There is cycle dependency. Many hormones, you know, and you see that every day, LH, FSH, antimilerian, vary throughout the menstrual cycle. So the calibration in order to avoid false positive is absolutely necessary. And finally, validation. We need a lot of research to validate this marker in large, diverse, and I insist in that, diverse cohorts. We cannot depend in a cohort from China or a cohort from Northern America or from Northern Europe. We need diverse cohorts in order to establish these markers in clinical practice. I'm going to share with you this paper, actually, that I think it's really interesting. This is what it shows. It shows the results out of almost 12,000 affected women that they were validated across 5 international cohorts. They followed the women for 6.5 years and for in vitro treatment data and revealed distinct reproductive and metabolic trajectories. So these are the subtypes I was referring before. The first one was hyperandrogenic PCOS that showed the highest risk of second trimester pregnancy loss and dyslipidemia incidence. The second was PCOS with obesity that had the most severe metabolic complications, lowest live birth rates, and highest remission rates. The third was PCOS with high SHBG that demonstrated favorable reproductive outcomes and the lowest incidence of diabetics and hypertension. And the fourth type was PCOS with high LH and adenomylarian that had the greatest risk of ovarian hyperstimulation and the lowest PCOS remission rate. So this actually an excellent review, an excellent paper that shows that if we understand the PCOS heterogeneity, we can provide a framework for subtype-based specific subtype-based risk stratification and personalized management. And actually, to continue this idea, I'm going to share with you 2 cases that they show how different we have to treat and manage the patients according to the specific subtype of PCOS they have. This is the first case that I want to share with you, a case with infertility and how it was managed in IVF. This is a 33-year-old woman with PCOS, and she has a 35-year-old male partner, and they have been trying to conceive for over 4 years. There was a history during these 4 years of failed intrauterine insemination and intracytoplasmic sperm injection cycles, despite normal semen parameters. The woman had abnormal LH levels and FSH levels. Counseling actually was tried and counseling was emphasized lifestyle changes in order to manage this infertility that is caused probably most likely by PCOS. Ovarian stimulation followed. They retrieved 17 oocytes, 8 moved to metaphase 2, 6 zygotes were produced during using intracytoplasmic sperm injection. They expanded in blastocysts and they were at cryopreservation, progesterone support, and then frozen embryos transferred. They succeeded. A successful pregnancy was concluded. This is actually a real case that demonstrates that utilization of controlled ovarian stimulation, intracytoplasmic sperm injection, and lifestyle modification can work effectively to achieve positive outcomes in pregnancy, and highlights how significant is the individualized treatment and guidance in managing infertility that is caused by PCOS. The second case I want to share with you is a case with PCOS and oligomenorrhea. Is a 24-year-old woman with hyperandrogenic signs, hirsutism, acne, and irregular menstrual cycles. On clinical examination, she had acne vulgaris on the face, no alopecia, no acanthosis nigricans. She had a waist to hip ratio of 87 and the body mass index 15.9. So low, right? Elevated testosterone and androstenedione and 17-OH progesterone levels. She had normal adrenocorticotropic hormone, normal cortisol, so no Cushing, normal prolactin levels, so no hyperprolactinemia, normal T3, T4, TSH, so no thyroid disorders. Insulin resistance was identified, though, through an oral glucose tolerance test, and treatment with metformin, of course, and dexamethasone was started. 6 months later, there was an improvement in menstrual cycle, improvement in acne, improvement in hirsutism. This is another example, actually, that highlights that when patients with PCOS also have insulin resistance, they may be normal or underweight, They require multidisciplinary approach to diagnose and management. And with this, I want to leave you some thoughts and some, if you want, take-home messages. The approach to polycystic ovary syndrome is shifting from one size fits all that we do symptom management model that we follow at the moment to a pathophysiology-driven precision medicine approach. This new area aims to use molecular, genetic, and data-driven insights to classify PCOS in distinct subgroups for personalized treatment, so we move beyond the broad Rotterdam criteria. Recent findings suggest that future personalized medicine approach could use these specific molecular profiles to improve diagnosis and treatment, particularly by targeting the underlying pathophysiology of the disease rather than just covering the symptoms. And finally, AI-based analysis of traditional clinical metrics like BMI, glucose, cycle tracking, combined with wearable data, will offer the most immediate path toward actionable digital biomarkers that can monitor or suggest an accurate and prompt, most of all, diagnosis of PCOS. And I want to finish with showing you this amazing paper that you already have seen several times, I think, during this course. It was published just last week, and it's the paper that is out of a global consensus that is trying to change the name. You see, talking about PCOS, like polycystic ovarian syndrome, it's not an accurate term. It implies just pathological ovarian cysts, and it obscures all these diverse endocrine and metabolic features. And it contributes to delayed diagnosis and fragmented care, and also stigma sometimes. So that is why these key opinion leaders came up with the change of name, which is not just a change of name, I think. It's a process that will imply publication and academic dissemination of the new entity, resource development, global communication and engagement, integration within the healthcare and health information systems, policy and research alignment, international classification and global bodies, transition and future refinement, and most important, guidelines. So there's going to be integration into the international guidelines that is followed already by 195 countries by 2028. I think this is going to improve the picture we have, maybe not the actual treatment, but the picture we have for polycystic ovary syndrome, this new name and new nomenclature. With that, I want to thank you very much for your attention, and I hope I can answer any question you might have. If you're still with me. Are you? Hello?
Yes, sir. We are thankful for you because your lecture is a map for the future regarding the personalized medicine. But there is a lot of inquiry about how can we maximize the benefit regarding the patient benefit and lowering the cost and the data entry, security of data entry.
Excellent topic. You see, the security of data entry is already been solved by ISO 27001 that I think most of the good labs around the world share. So there's anonymized, of course, data that we analyze, and it's both sides anonymized. So only the physician, the treating physician, knows the actual name of the case of the patient. So this has been solved. The cost is a major factor, and it's a major problem. And you're absolutely right. Still, cost is quite high. And this hopefully is going to be lowered by the competition of different companies that they come into game. You see, for example, in sequencing, in order to find the mutations in genes, We used to do sequencing, and we still do sequencing, right? NGS, etc. And it used to be only one company in the world. Now there are at least 7. So you see this spread and competition is going to lower the prices very, very soon. I'm pretty sure about that. AI also. There's a lot of companies that they get into AI and machine learning. So this competition will lower the cost. Unfortunately, you're absolutely right. The cost is a major negative factor.
Sir, many of the attendees thanking you. And there is one question from Mariam Ismail about the use of GLP-1 in obesity associated with PCOS.
Right. GLP-1 receptor agonisms actually are already being used, you know, that to treat obesity. And I think, and this paper actually describes it very clearly, that in order to deal with obesity, other than lifestyle changes, GLP-1 receptor agonisms can help because obesity makes the whole situation even worse. So at least this can help a lot. Weight loss can help. It is contraindicating during pregnancy, but hopefully by the time you succeed with pregnancy, you're going to stop it, right? And lifestyle changes after that will take over. At the moment in Greece, at least, the OBG, the gynecologists, what they do when they use GLP-1 receptor agonists, they continue them until they have conception. Once they have conception and the patient continues with just a lifestyle change, they can stop them because, as you know, they haven't been tried during pregnancy, and I don't think that they should be given during pregnancy. Of course, I'm not a gynecologist, but I don't think it's safe.
The last question. There is any effect for environment about the prognosis, the diagnosis, and the treatment of PCOS? This is a question of Toa Mustafa.
Environmental factors, yes, this is also an interesting field. At the moment, we don't really know details about how environment affects PCOS patients, but we do know that environment affects the expression of genes. I will give you an example that you probably are familiar with, microbiome. The environment, and when I say environment, I don't only talk about atmosphere and everything. I talk about nutrition. I talk about the way we move, of exercise, and all these external factors on the human being. So this definitely affects microbiome health. And of course, microbiome takes part to everything, right? So by environmental factor, each one of the environmental factors could affect the expression of genes, but details are not ready known yet, unfortunately.
Yes, sir. Professor Bent, please, at the end of your very nice and informative talk, in behalf of American Association, I am thanking you. Thank you.
Thank you so much for the opportunity, and I hope to take part in another session as well.
Yes, you are most welcome. Our next talk will about AI for OB/GYN for high to critical practice. Our speaker is an engineer, Mr. Kumar. He will help us in understanding the role of AI in OB/GYN practice. You are most welcome, sir.
Okay, hi everybody. And thank you so much, first of all, for inviting me at this amazing, I would say, community. And this is privilege for me as an engineer to be with all the doctors. And today, every one of you must have heard about how the AI is emerging. And if you have heard about Google has just recently launched in last week many different updates, which will be so helpful to all the doctors, how they can be more effective. But before, I just want to let you know that you must be here about hearing AI, but this session is not just about AI. This session is about actionable insights, right? So how you can implement AI, how you can literally make your 2 days of work in just 20 minutes. So that I'm just going to show you. So I have everyone two screens. One is on this side and one is on this side. So I may possible that I may look here or here, but still I'm with you. Yeah. So how many of you are ready? Write down R in the chat box quickly, everybody. How many of you are ready to explore AI? How this AI will, impact this industry? Write down R in the chat box. R for ready. Quickly, everybody. Okay. Thank you. Amira is ready. Still people are writing. R for ready. Okay. Toka Mustafa, Rana, thank you. Fatma, thank you. Yeah, Nivin, thank you. Thank you, thank you, thank you. Okay, right. So the thing, my dear friend, I just want to tell you that these are some of the famous tools you must have heard about. It is ChatGPT, Claude, Gemini, Meta AI, Perplexity, Toco, Pilot, Midjourney. So these all are the tools which people are using. But today I just want to tell you that how this tool will be useful and you can use it like a toy, right? Many times I have seen, and I have a privilege to be with doctors, I have privilege to work to implement artificial intelligence in their hospitals so that they can be more super effective about report analysis, about minimizing their writing work, about minimalizing discharge work. Many different things are there where we implement AI. So before that, I just want to let you know that AI is a new electricity. And if I say about electricity, it took 100 years to just get spreaded all over the world. But artificial intelligence is the something which just took 4 years to be in this whole world. Nowadays it happens that a guy who is in school, right? He's of 12 years or 13 years, he knows also AI, and 60-65 years of people are also exploring AI. So AI is just like a new electricity. I just want to tell you that if electricity is not in the world, just imagine if electricity is not there, then how the world will be. Suddenly some things are there that will get started disappearing, and slowly everything will be there which is we are which is available for us for our comfort, that will be disappeared. And this is how this AI also a technology which is the new electricity. Yeah. And I just want to tell you that AI is a simple clinical assistant for information processing, communication, documentation, and patent support. How? Let me differentiate this AI in two different sectors. The first is generative AI and second is clinical AI, right? Generative AI generally supports you to be more on digital platforms, like where you are engaging your target audience, where you are engaging your customers, where you are engaging your prospect. And clinical AI is when your client is there, when your patients are there. At that time it will help you to make your daily life easier. Yeah. So if I say about generative AI is moreover for documentation overload, charting burnout, repetitive task education, multilingual patient communication, discharge instructions creations, and social media or public health awareness content. These are some topics where generative AI can be helpful. In India, where I live, at that time, generally people have the concern that there are multilingual people come for the treatment, and at that time, it happens that a particular patient is not getting what the doctor is saying, or the doctor is not able to understand everything what patient want to say. At that time, the generative AI comes in the picture. Yeah. Let's say about clinical AI. When clinical AI comes, at that time I can say, let's say if any patient is of breast cancer detection or something, IVF embryo selection, ultrasound measurement automation, these all are the use cases where you can implement AI. Now, when AI comes in the picture, at that time prompt comes. What is prompt? If I say, if I tell anyone that what is prompting, then prompting is just like a commanding something or commanding someone, that is prompting. So prompt engineering is the vast word in this world. If you heard about artificial intelligence, you always heard about this prompting. but how to write effective prompts. So before moving on, I just want to tell you the 4-step simple formula, right, by which you can make easiest and effective prompts, which will help you to make you more better performer. Now, let's say for that, I just want to give you a simple formula, and that simple formula is super child formula. Everyone, prompting formula is super child formula. So everyone write down in the chat box, it is PF. Write down in the chat box PF, that is prompting formula. I am going to tell you that how this super child formula will help you to write more and effective prompts. Yeah. Okay. So quickly, everyone write down PF in the chat box so that I can see that how many of you are with me. Okay, thank you so much. Thank you so much, Toka Mustafa. Thank you so much, Niveen. Thank you so much, Nalja, Iman. Thank you so much, Fatma. Thank you. Thank you. Thank you very much. Thank you very much. So keep writing, everyone, what it is PF. Now, just consider that any 12 years or 13 years of child is there with you and you are telling him to get the ice cream. Simple, right? To get the ice cream. So how many things you will tell them? Which flavor they need to get, what kind of ice cream they need to get, how much it will cost, from which store you need to just get it. So you are just telling it different category of questions, right? What to buy, from where to buy, what is the amount to be paid, what will be the amount that will be returned after the purchase, or from which store it is to be purchased. Everything you are going to give this information to that particular child. And when you give this instruction, at that time, highly chances are there you will get the exact ice cream which you want at your home. And the same thing happens with this GPTs, right? So whenever you want to get any specific answers, at that time, my dear friend, whatever things are come to your mind, at that time, you'll have to add everything. But the question is, people don't have the time to write the effective prompts. So for that, we have made one solution that I just want to tell you that what solution we have created. And that solution is Ultra Prompt Generator. Yeah, this is a simple machine which we have created inside ChatGPT only. I'm sure you must be aware about ChatGPT, Gemini, different AI tools are there. Let's say I just want to write any simple prompt which will be helpful to a doctor. Yeah. So I will just write down, say hi. Whenever I say hi, at that time, it will give me some instruction and it will ask me two questions. The first question is, what is your profession? And what is the final result you want to achieve? Yeah. So I'm just copying this and I'm answering this two question to this. Let's say my profession, I am, let's say, gynec, right? I am gynec. Just a minute. Okay. And what is the final result? Which, just a minute. Someone is writing on the screen. Let me stop it. Yeah. Okay. Got it. Clear all drawings. Yeah. So what is the final output you just want to achieve that? Let me write it down. I want to create a 30 days of awareness campaign for my uh, prospect, where I'm going to tell them how this PCOS can affect their daily routines and how it can be solved. So I want to aware this all my prospect, and the target audience will be between a 30 to 50 age group of women. This is simple prompt which I have given to this ultra prompt generator, and these are the basic details, right, which any doctor can write. And when you give this basic detail, it will write a specific and detailed prompt for you. Yeah, so this is what the exact detailed prompt. It is act as a senior women's health awareness strategist and gynecologist with expertise in PCOS education for women aged 30 to 50. Create 30 days of awareness campaign for my prospect and target audience. Focus on how PCOS affect women's daily routine and how it can be managed or solved. Include 30 days of content ideas that explain the impact of PCOS in energy level, weight, mood, sleep, menstrual cycle, fertility, skin health, and emotional well-being. All the detailed prompt is written down here. Now just think about, everyone. Just think that if you give the basic detail and if you give this detailed prompt, where you will get the better result. Option 1 or option 2? Just do let me know in the comment. Option 1 or option 2? Option 1 is you are just simply writing down, give me 30 days of awareness campaign. And in option 2, you are giving the detailed option, right? So where you will get the best output in option 1 or option 2? Write down everybody in the chat box. Okay. Fatma is writing it is 2. Okay. Nivin is also writing 2, right? Najla is also telling OP2, option 2. Sabah is also telling OP2, option 2. Iman is also telling option 2. Simple, right? So this is the detailed prompting, right? Just like I have ordered an ice cream. So everyone, if you want to write a detailed prompting, just use this 4 simple step formula. Now I just want to let you know that which 4-step formula I have used here. So this is the 4-step simple formula. Okay. The first formula, it is define a clear role for anyone. Let's say act as a senior obstetrician and gynecologist with 20 years of experience, of clinical experience specializing in infertility, pregnancy care, and women's wellness. Step 2, start with a clear instruction. Explain how AI can improve patients' experience and operational efficiency with OB or gynecology. Number 3, that is specify the context, and people generally make this mistake where people don't specify the context. And when you miss it, you will not get the specific output which you want in your GPT talk. Yeah. So that is focus on small and mid-sized fertility centers. I have just written it for India. You can write it down for your country, and that want to increase patient trust, manage reviews, and provide personalized consultations. And number 4, set the desired tone or style. That is optional, but I highly recommend you don't keep it optional. Yeah. And the final prompt is ready with you with role, instruction, context, and style. So everyone, when you just add this all for things inside your specific prompt, you can get the better output. Now what I'm going to give you, you can generate a specific frameworks with your name, everyone, right? And when it is your name, at that time it also helps you with your personal branding too. Let's say I'm just getting some specific or any random name, right, where I can see the name is Toka, right? So I'm just creating one framework. So I go to ChatGPT and I will write down ChatGPT to create a framework. So I'm writing, I want to create a framework with let's say I'm creating for with my name, right? It is BHAUTIK. Sorry, UTIK. Yeah. So I'm also giving some that I want to use this framework to make OB and gynec doctors to be more effective at their daily routine so that they can be more productive and they can achieve 10x faster results to get more patients and to be more effective, and they get time freedom. Yeah. And they will use this the particular framework at I, I'm not adding that, but with this specific context, you will get the uh, detailed result. And this is the simple framework which I had created for gynecs. Let's say it is first B for better trade, then H for health documentation automation. Everyone just see the magic where I have given it the context of creating this for gynec and obstetricians, and it is creating that vocabulary in my name. Yeah. Okay. Then it is H for health, A for AI patient education, then U for ultra smart follow-up system, and T for treatment decision support, I for intelligent marketing and patient acquisition, and K for knowledge multiplication. So the thing, when anytime it comes to the framework, you can create your framework, use that framework, and after that framework, you can create the prompt. Everyone, right? So get everything with you, use different category of framework. Different frameworks are available. Let's say if you go to the Google, and search it out that give me top 5 framework to use for gynec digital growth, and it will give you the top 5 framework. These are the framework. See, it is STDC framework, local ACO framework, then 72010 framework, PPE framework, that is patient persona empathy, right? Then conversational marketing framework. These all are the frameworks you can literally use in your daily routine. Yeah. Okay. Right. So these are the things you must add in your daily life. Now, what is the biggest bottleneck? And the biggest bottleneck is time, patient communication, and documentation. With many doctors, I have seen that they are stuck, that they want to give the better care, but they are stuck at paperwork. They want to give the better communication to their patient, but they are not able to give the sufficient time, as they have lot many patients to be engaged every day. Yeah. So this is the biggest bottleneck. Now, where actually AI can help you, everyone. First, IVF patient, where you can create a machine which will help you to solve their any questions, right? Any FAQs are there. I'm going to give you a demo, right? Which you can see that it will be so easy for anyone to use. Then you can create any different presentation, social media awareness content. If email overloading is there with you, you can also use AI. As I told you, Google has given the many major updates nowadays in last week, where it can solve all this problem so easily. Yeah. So now, everyone, what I'm going to show you, right, is amazing thing which I have made, or I could say you will be amazed with this. I am sure, because whenever I go to the doctors are okay. Is my voice clear, Mohammed? Is my voice clear? Someone is writing that raise your voice, please. Okay,
Yes.
is my voice clear? Okay, yes, my voice is clear. Okay, got it. So I have created one patient's calling agent, right? It is counseling agent, where with this agent you can literally talk. Okay, so I'm just talking it. You just listen it so that you can get more information about it. Yeah. So this is about PCOS counseling, and any patient comes before, if any patient come to the clinic before it can talk to this doctor. Yeah. Okay. So this is what I'm starting. Hey there. Hi.
Hi, I'm here to help you feel heard and guide you toward next steps. Before we begin, would you prefer we speak in Gujarati or Hindi?
I just want to speak in English only.
That's absolutely fine. We'll continue in English. So let's start by understanding you. Can you tell me what symptoms or concerns you're experiencing right now?
Yeah, actually, I have seen that PCOS is continuously, draining my energy and decreasing my productivity. So, how it will be possible that I can solve it, and what are the best ways to, get out of it?
I completely understand how PCOS can affect both your energy and your day-to-day productivity. The best approach is personalized. At Smith Hospital, we'll start by fully understanding your symptoms, your cycle, and your lifestyle. Once we have that picture, we can guide you through tailored steps, whether it's lifestyle adjustments, hormone balance support, or other medical options. When you're ready, we can arrange an appointment to get you that personalized plan.
See, everyone, I have just muted it, but this was made for Smith Hospital. So during that call, it will speak the name of that hospital, and we have trained it in such a way that every time when you complete the conversation, at that time, guide our patient to be at hospital, to come at the hospital, to take counseling for our doctor. So it also, add that, okay, can I help you to arrange any any appointment or any personalized plan which you can move on, right? So I'm just continuously talking with it. Yeah, okay, but I just need to ask you that what are the probable ways which will help me to solve this? Why should I go at clinic?
So, the reason for visiting is that PCOS can show up differently for each person. At the clinic, we'll personalize solutions, whether that's managing hormones, improving lifestyle, or fertility support. The benefit of coming in is you get expert guidance, no guesswork, and we can track your progress. It's all about a plan that actually fits your body and life.
Got it. So how can I book the appointment?
I can help you with that. Once you feel ready, we can set a date and time that works for you at Smith Hospital. Would you like me to help arrange that now, or would you prefer to think about it and reach out later?
So 22nd of May will be workable for me at 5 p.m.
Noted. Let's set you up for May 22nd at 5 p.m. I'll make sure your appointment is arranged. We'll be ready to welcome you, and Dr. Vithal Patel's team will take it from there. If you need anything before then, just reach out.
I got it. Thank you so much. Thank you. See you.
You're absolutely welcome. It's been a pleasure chatting with you. If anything else pops up or you need any more guidance, I'm here. Until then, take care of yourself, and we'll see you at your appointment.
Got it. Thank you. Simple, everybody, right? So this is how you can create all these agents for you in ChatGPT. Just the thing is that you need to train it. When AI comes in the picture at that time, you will have to train it in such a way where it understands your language, it understands your problems, it understands the things which you want to show them that okay, these are the things which I can solve for my particular problem. As I told you, generative AI is there, clinical AI is there, generative AI is more useful for documents, right? So I am giving you the amazing tool. Everyone, every doctor must use this, and that tool is Notebook LM. What Notebook LM does, the magic in this Notebook LM is it doesn't have any data. It works on specific data which you have given to this tool. Yeah. So let's say I have one of the file which I had created for, let's say, PCOS presentation is with me, and it will learn everything from this presentation. And now I want some audio overview. I'm just giving him some instruction that explain all the things without any jargon. So it will create an audio for me from presentation to audio summary. Let's say if you have any report of any patient, let's say it is of 2 pages, 3 pages, just give this and tell it to create an audio overview. You can make video overview too, right? It is just, first of all, it is just getting PDF is just being added here. I'm just telling it, deleting it. See, till the time it doesn't have the specific resource, it will not start acting. Okay, so first it will summarize the document for itself only. First it will get all the details, and then after it will tell you that how you can get the best results. It will generate the audio overviews, slide decks, video overviews. It can also create mind maps for you. It can create reports for you. It can give you flashcards. It can create a quiz for you. It can give you infographic, and it can give you data table too. If you have any MS Excel file, Google Sheet file, you can literally upload inside this, and after uploading it, you can create the data table of it. And that data table again will be so helpful to you so that you can understand easily. Right now it is taking some time. Okay, right now it is taking some time, but I just want to tell you some previous things, right, which we have covered inside this. Yeah, so this is the 5 pillars of perfect business opportunities, right? It was there. I didn't create anything. Okay, yeah, this is the first roadmap to create first $100K, right? This is the summary which we had done, and this is what the video it has created. Okay, everyone, just be with me. And it can literally create these videos for you. And
Viral videos suggest that wealth happens in a single lucky weekend. But for anyone starting at zero, these stories are distractions that hide the actual mechanics of building a financial foundation. If your brain is occupied with the math of grocery prices or the arrival of next month's rent, you are physiologically incapable of long-term strategic planning. Survival stress forces you to trade your future for immediate relief. To bridge the gap between daily panic and strategic growth,
yeah, second thing, it can also create audios too, right? It is in Hindi language, but you just hear, right? How, what next level of AI audios it can generate. So I'm just playing it.
इंसान को दुनिया का सबसे आजाद और अमीर व्यक्ति महसूस होगा। लेकिन
This is
आज
also
की चर्चा
100%
जो
AI audio summary which I have given
Sorry
to
to
this.
interrupt you, sir. We are exceeding the time. You still have 2 minutes, not more.
Okay, got it, got it. Thank you so much. Thank you so much. Yeah. So another thing, it is the one-page roadmap it is created, right? So this is what the thing. It is also 100% AI. So my dear friend, whenever you are utilizing this, whenever, yeah, it is not about implementing, something, but it is about getting the problems and solve using AI. Everyone, right? So start solving the problem using AI, right? And yeah, and someone is writing that, okay, my advice in my last lecture is make AI is your best partner, but no, don't rely it. Very good. So amazing advice it must be, because it is not about depending on AI, but you will have to add your wisdom. What people does, they just copy thing, paste it down, but they don't add the wisdom, and then after, the different things or different mashup comes into life. Yeah. Okay. Someone is asking what is the fourth step. I just want to let you know I have already created that fourth step, but let me again share it. The fourth step is about setting the desired tone or style. It is optional, but I highly recommend that don't make it optional. You just add it. Let's say use simple conversation tone suitable for gynecologists exploring digital transformation. This was the fourth step. These are the 4-step simple formula. You can use it to create the best prompt to get the higher category of next level of results for your life, for your daily routine life, which will make you more productive and more effective. Another aspect is about machine learning, where in machine learning, you must have seen the video where doctor is doing a surgery at his place and the patient is at different location. So that category of machine learning is coming in the world using AI. Yeah. So this is what all from my side. Thank you so much, everyone, for giving me this opportunity. Yes, over to you. If any questions are there, then you can
Yes,
ask.
we are all thank you, Mr. Kumar. My question is against the wave. What is the are the drawbacks of AI to be used in OB/GYN practice?
Okay, got it. So as I have created that clinical practices, clinical AI is there. So whenever you are giving any report to AI, at that time, many different things, AI is still in the learning mode. It is always learning. So whenever you are getting any output, at that time you recheck it first, right? At least 2-3 checkpoints must be there, and because it is a doctory, and any a little mistake can make a big things. So whenever anyone is implementing any AI, at that time always recheck it at least with 2 or 3 checkpoints.
Yes. There is a saying, by any means, AI is not exceeding the intelligence of a child aged 6 years. What is your opinion up till now?
Could you please repeat the question? Could you please, it was not audible. Hello?
Yes?
Yeah, could you please repeat the question? It was not audible.
Yes. There is a saying, AI is not exceeding the intelligence of 6 years child up till now. What is
Okay.
your opinion?
Right, got it. So nowadays, as I told you, Google is updating all the data. So AI is in last 4 years, when initially it was launched. At that time, it has It has the intelligent till 2021. Then after 2022-23, it has started gathering much data. And nowadays, the way we are using it, right, it is gathering the data, and many different tools are there. Let's say in India, Perplexity is there. You must explore it. Perplexity is the best tool for research because it has the live data, right? It has the live data to research. Yeah, so artificial intelligence is still being intelligent to get the real-time data, but it will take some time, around a year, where it will be so easy, where it all the AI tool has the real-time data, which are make and any people very good at research.
At the end of your talk, we are thankful in behalf of American Association and our distinguished attendees. Thank you, and we are hoping for your sharing in the future meeting.
Got it.
Now,
Thank you so much. Thank you.
Now, it is the time for me. I am Muhammad Salam Agad, Professor of Ops and Gynae, Minopia University. I think by the end of this meeting, my talk will answer many of the unanswered questions and is a summary for all done. PCOS is now PMOS. Man. Yes, as we know, the evolution nomenclature for PCOS, as Professor Osama said, is a long story, exceeding more than 90 years. But the three main stops is Stein-Leventhal in 1931 and Ishri Asram Rotterdam criteria in 2003, and lastly, 10 days ago, by the Endocrine Society during the 12th of May 2026, saying PMOS. There is a change, and the change was a prompt one. Why? For PCO to PMOS. This change is for an accurate reflection, reduce misunderstanding, and improve the diagnosis and the care. This issue was led by Professor Helnan led and published in Lancet. Going back to the present, the importance of PCOS, as one of the speakers said, it starts from womb to the tomb. It is not a disease, but a syndrome with varied presentation. PCOS has a continuum spectrum starting from early pre-pubertal years and continuing even after menopause. Insulin resistance is the key finding, and there is a four sibling to be included: obesity, diabetes mellitus, lipidemia, and hypertension, acanthosis, fatty liver, sleep apnea, and sometimes endometrial carcinoma from the unopposed estrogen production may occur. The spectrum and the clinical manifestation of PCOD, including many items, but the most important are irregular menses, acne, hirsutism, obesity, acanthosis, hair loss, and infertility and pregnancy loss. PCOS has a short-term and long-term sequelae. The short-term, including obesity, infertility, irregular menses, abnormal lipid liver and hypertension, hirsutism, acne, androgenic alopecia, glucose intolerance, increased early pregnancy loss, and gestational diabetes mellitus. the long-term sequelae, including diabetes mellitus, endometrial cancer, and cardiovascular disease. We can summarize the long-term complication by this figure, including it is the most common endocrine disorder in women. The symptoms may include chronically irregular or absent period. Symptoms may include facial hair, central obesity, and acne. Let's understand it may lead to heart disease. Left untreated in may lead to uterine cancer, and it is a most common leading cause for anovulatory infertility. So there is a confusion, worried, distress, and unsure, and anxiety. And many patients and scientific committee for more than 14 years were looking for an answer. PCO is now PMOS, a name of 170 million women have waited for after 14 years of global collaboration and over 22,000 survey responses and landmark rename published in Lancet on May 12, 26. Finally, it reflects the true complexity of the world's most widespread hormonal condition. It is a global decision, as I said, including more than 22,000 responses. It is a worldwide workshop. The voice from women and clinicians and 56 societies, including every, and the meaningful step forward driven by evidence, global collaboration, and lived experience. PCOS is just become PMOS. PMOS has a new name and is now known as PMOS, as it is the acronym for polyendocrine metabolic ovarian syndrome. The three PMOS pillars, that is to say again, polyendocrine hormones, metabolic health, and ovarian function. By application of this, there is a limitation focus in the misleading ovarian cyst, and nowadays they are universal. Again, the new term polyendocrine metabolic ovarian syndrome, PMOS, concentrate in a polyendocrine dysfunction, ovarian dysfunction, and other symptoms. The goals for nomenclature shift, including improve diagnostic clarity, reduce patient understanding and stigma, and allow with evidence-based treatment. The three PMOS pillars, as I said, are illustrated in this figure. What happened next? There is a shift and a change. What happened next? First of all, it is published in the Lancet, and as we know, Lancet is one of the most believed magazine in medicine. Also, PMOS is now a new name, and the resources are freely available, but there is a 3-year global transition from PCOS to PMOS. Yani, we can use both terms for 3 years. Education, awareness, and inclusion in the 2022 28 BMOS guidelines. Again, there is a 3-year waiting time to give a guideline for the new name BMOS. The treatment hasn't changed. It is the same for PCOS with the same guidelines. No change, except the ultrasound criteria. That is to say, ovarian cysts are not included, and they, if not present, they not antagonize the diagnosis of BMOS. Management strategy remains the same, but the new name is expected to ensure all dimension and treated not just fertility. The proposed renaming, as I said, was published by the Endocrine Society in May 2026 in Lancet, and it was a breaking news and get the attention of more the gynecologists and the endocrinologists and even pediatrician doctors. PCOS is now BMOS, and this is approved on the second day by Ishri Asram. And one day after, yani since 7 days, Royal College approved the new name. Why? Because BMOS by number is present in one in every woman. It affects more than 1,070,000 women all over the world, and there is a more than 14,000 new survey responses every year, and the study included 56 societies, and in spite of that, 70% is still undiagnosed from the case, but the assuring item is the 3 years waiting to incorporate completely the new name. Why old name was a problem? Because, as I said, the cyst label is out. The whole body syndrome is in. It is a very nice saying. The cyst label is out, and the whole body syndrome is in, and the old name might have contributed to delay in diagnosis, fragmented care, stigma, and patient dissatisfaction. PCOS compared with BMOS showing the shift away from cysts towards the whole body care. The whole body care items including endocrine, as androgen, insulin, AMH, and neuroendocrine signals, metabolic as glucose, lipids, liver function, and cardiovascular risk, including reproductive and ovaries as anovulation and infertility. Also, including the woman's stigma in the skin as acne, hirsutism, hair loss, and the most important one is the mental health. What the patient can do with the change of this name? In all homes and among the lay females and the mothers, even the couples, the old saying of PCOS is a trade name, and sometimes wrongly may be the answer of infertility. But for patient can nowadays until and for coming 3 years can use both names BMOS and PCOS, and the most important item, and can ask about the metabolic screening and track the full pattern, and don't let BMOS explain everything. This is a dictum saying, don't let BMOS explain every symptom. Anyhow, PCOS is now BMOS. The coming 9 slides are delivered by Ishri and Asram, and it is a very illustrative slide summarizing the problem. What is BMOS? BMOS stands for polyendocrine ovarian syndrome. It is the new medical name for PCOS, and the renaming was efficiently proposed through global medical screen consensus published in the Lancet, I said. And why was the PCOS renamed? As we said, the term polycystic ovary syndrome focused too much on the ovarian cyst, and the BMOS highlights the whole body nature of the disorder. Thirdly, the full form of breakdown of BMOS include polyendocrine metabolic ovarian syndrome, and these are the acronym for the new name. The major symptoms including irregular irregular or absent menstrual period, excessive hair, acne, oily skin, weight gain, and difficulty in losing weight, hair thinning or hair loss, difficulty in conceiving, infertility, dark skin patches, acanthosis nigricans, and mood disorder, anxiety, and depression. The main causes of and risk factor, the key for that is insulin resistance, is the androgen hormones, hormonal imbalance, chronic low-grade inflammation. PCOS again is now BMOS. The diagnostic criteria is still the Rotterdam criteria, including irregular ovulation and or irregular period, high androgen level, or either by the lab or clinical, polycystic ovary on ultrasound in adult, but not in adolescent. The health complication including type 2 diabetes, obesity, high blood pressure, heart disease, infertility, sleep apnea, endometrial cancer risk, mental health disorder. And the treatment and management, as we said, are the three main pillars. Number one, for all ages, dietary and lifestyle changes, and we will say here in the next lecture. Number two, the treatment is mainly symptom directed, especially in adolescent, and the infertility, as Professor Nashar said, has alliance, and this is an evidence base. The global information of the climate change that they said over 170 million women worldwide, occurring in every 8 women, with the renaming followed for 10 years global study, and the year of 2028 will be the end to use the old name. At the end, we can say PCOS or BMOS is a never-ending story. in Arabic متلازمة تكيسات المبيض قصة لا تنتهي. How? From India, a well-known professor saying, don't change the PCOS, we can just change the meaning. That is to say, B polyendocrine, C, cardiometabolic, O, ovarian, and S, syndrome, to avoid misleading. But this saying not accepted, and he published this since 5 days ago. What is the most new coming change? This is another breaking news. PCOS is not the end of the story, but PCOS is another coming story through pelvic overlap spectrum syndrome, including endometriosis, adenomyosis, pelvic floor dysfunction, bowel and bladder dysfunction. My dear audience, PCOS and the PCO must be used for the coming 3 years. The lines of treatment are the same, published and approved by ASRAM, especially the 23 and 25, the year of 23 and 25, and we are waiting for the new guidelines during 28 to 2028 year. Thank you for your attention, and many thanks to American Association for this nice gathering with this distinguished speaker and elite audience about a new comer regarding the name. And I am happy to receive any question. Yes? 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 Any questions? Any questions? So I will be happy to introduce the coming speaker, Mr. Dr. Hani Abu Naga, who will address us about nutrition in PCOS for dietary confirmation to evidence-based guidance. You are most welcome, Dr. Hani.
Thank you, Dr. Muhammad. Thank you for the great talk.
Yes.
A short video on our coming conference for the American Association, AAGC. Then Dr. Muhammad Abu Naga, Hani Abu Naga, sorry.
We are back again. Who we are? We are AAGC. And the numbers will speak up. Millions of women around the world regain their confidence, comfort, and quality of life. Through the power of aesthetic gynecology, a specialty that goes far beyond beauty, it's not a luxury, it's healthcare. Behind this impact, over 8,000 trained doctors, 450 certified training programs, and 35 major scientific conferences. We pioneered aesthetic gynecology and changed the game, and now we are bringing that exact same unmatched leadership to the entire spectrum of women's health. Introducing 4 mega conferences under one roof: the Aesthetic Gynecology Conference, the Gynecology Endoscopy Conference, the Pregnancy and Beyond Conference, and the Infertility and IVF Conference. 4 conferences, 1 platform, infinite impact. We are bringing together the pioneers shaping the future in the Middle East. July 16th to 17th at Hilton Cairo Grand Nile. Register now to be part of the movement.
Modern patients are no longer searching for temporary solutions. They are looking for true restoration. They want science-driven transformation. Today, this field goes far beyond traditional cosmetic procedures. The future is built on cellular renewal, advanced biostimulation, and evidence-based regenerative medicine. Because patients today expect more than routine treatment. Learn the protocols shaping the future of women's intimate wellness. Not by watching, not by theory alone, but by practicing every technique yourself. Learn patient assessment, diagnosis, treatment planning, and procedural precisions. Learn the latest injectable protocols, tissue restoration strategies, and modern regenerative alternatives. Because expertise means knowing how to explain science clearly and guide patients. Coming for leader. Register open.
We are back again. Who we are? We are AAGC. And the numbers will speak up. Millions of women around the world regain their confidence, comfort, and quality of life. Through the power of aesthetic gynecology, a specialty that goes far beyond beauty, it's not a luxury, it's healthcare. Behind this impact, over 8,000 trained doctors, 450 certified training programs, and 35 major scientific conferences. We pioneered aesthetic gynecology and changed the game, and now we are bringing that exact same unmatched leadership to the entire spectrum of women's health. Introducing 4 mega conferences under one roof: the Aesthetic Gynecology Conference, the Gynecology Endoscopy Conference, the Pregnancy and Beyond Conference, and the Infertility and IVF Conference. 4 conferences, 1 platform, infinite impact. We are bringing together the pioneers shaping the future in the Middle East. July 16th to 17th at Hilton Cairo Grand Nile. Register now to be part of the movement.
At American Association, IVF education means learning what top fertility experts actually do. Understand the full science behind ICSI. and when it truly improves outcomes. Learn modern stimulation strategies trigger personalization, freeze all decisions, and AI-based embryo selection updates. Here, every doctor manages one case from diagnosis to protocol planning and fertilization strategy. Learn exactly when to shift protocols, optimize ovarian response, and make evidence-based treatment changes. Because great EVF doctors know how to convince patients through trust, clarity, and science. Master clinician embryologist collaboration and make better treatment decisions. Poor responders, implantation failure, severe male factor, advanced decision making. This is where IVF doctors become clinical decision makers. Your next level starts here. Registration is now open.
Sorry for the delay. Dr. Hani Abunaga will join right now.
دكتور هاني Abunaga. طب until Dr. Hani prepare himself, there is many inquiry from the audience about the certificate and the availability of the lecture. You can get this lecture through the organizing committee of American Association, and also I think regarding the certificate, they will distribute it according to the rules. Dr. Hani will address
Hello,
us.
sir. How are you? How are you? How are
Yes, about nutrition in PCOS from dietary confirmation to evidence-based guidance. You are most welcome, Dr. Hani.
It's my pleasure. It's my pleasure, sir. It's my pleasure. Let me start with how to identify the problem from nutrition aspects. First of all, I'm Dr. Hani Abunaga. I'm a PhD nutrition, clinical nutrition from Miami University. I'm a professor of clinical nutrition in MSA and Khalifa University in Abu Dhabi. When we
Mr.
talk,
Hani, please share screen.
Share screen. Are you fine with that?
Yeah, join meeting. Just join, but not the slide.
You need the slide. I was about to talk, then share the slide.
Yes, you can go.
Okay. Give me a second, please, to share with you the slides if you want. Then we talk about the clinical nutrition and the relation with PCOS.
If you have a slide, it will be better for the attendees.
Of course, it will be better. Now
Yes.
Okay.
Nutrition role, yes.
First of
Nice.
all, when we think about the PCOS or PMOs, the difference in clinical nutrition will be the core of the problem. We know that it's a kind of major complex hormone problem that includes the LH and the androgens. So in nutrition, when we think about it, we think about the core that can increase the androgen. The insulin increase in PCO patients will increase the ovaries to produce, will push the ovaries to produce more androgens. And other step that the LH will be increased. So when we think about the core and nutrition aspect, we think about minimizing the insulin and how to help in minimizing the insulin. This is what exactly our main role. Second role will work on the inflammation that is associated with the PCOS case. So when we think about insulin that is already increased to cause the problem of PCOS, we start thinking about reducing this by checking if we have insulin resistance. This will give us a clear picture to the case. When we see that we have HOMA-IR or HOMA-IR2, or we have hemoglobinated sugar increased. This is how we help the patient to decrease the insulin level in order to decrease the androgen, which is definitely will affect the LH hormone in the pituitary gland. This is how we look at it from nutrition aspects. How can we do this? First of all, we look at the low glycemic index. I hope everybody with us here knows what is the glycemic index and how we work with it. And we think about carbohydrates from a different aspects. We go for lower glycemic index, like oats, like quinoa, like sweet potatoes, like moderate fruits and fibers and vegetables. In the same time, we look after the inflammation. Some food will increase inflammation. On the top of it will be the sugars, the high fatty foods will increase, juices will increase the inflammation while dealing with the case. So in nutrition, we look at helping people to reduce the core reason, helping people to reduce the problem itself, which increasing the inflammation that happen with the PCOS. Majority of people that come to our clinic with the PCOS has slightly overweight or maybe severely overweight. And the obesity is associated at least with the 40% with the cases. So when we help people look after it, this is what we're going to do. So the primary underlying factor is insulin resistance. Elevated insulin stimulates the ovary to produce the androgens. Androgen distribute ovulation. And this is one of the major cases when women come to the clinic and ask that they have a problem to get pregnant, because this is the androgen problem will increase the LH hormones level. The result will be irregular menstrual case that will increase during this case. Of course, we have an evidence that shows before even analysis that you have a problem, which is the hair that grows more in face and arms. The main role of nutrition to lower the insulin level and lowering the inflammation, as we said, we have to lower the white flour intake, which is the majority of the people goes for that, sweets, juices, and white bread. Low glycemic index carbohydrates, as I mentioned, oats, quinoa, sweet potatoes are really important, shifting from high glycemic to lower glycemic. Moderate consumption of fruits is important, and the increase of protein is really important because this will add to the satiety level for the patient. Inflammation is one of the core that we need to help. Leafy vegetables, turmeric, strawberries, blackberries are really important to lower the inflammation. Avoiding junk foods and hydrogenated oils. Adding omega-3, magnesium, and zinc is really important, and checking for vitamin D levels. Vitamin D levels are very tricky in our country. Most of the people are really having a problem with vitamin D, although we are the sun places or the sun countries, but we do have a major problem in that. So if you are a nutritionist and you need to think about any cure or any add value to your patient, you have to think about the core. And here we think about the core of the PCOS. Simply we'll go for the insulin problem, then we think about the inflammation. This is how we deal with the problem. If you want to add a simple dietary program for your patient. If you're working with the PCOS patient, think about increasing protein portion according to the appetite of the patient. Think about increasing the low glycemic index carbohydrates, thinking about vegetables, thinking about leafy vegetables, increasing all the food that can cause less inflammatory. As we mentioned, all the berries, blackberries and strawberries will add and help to the problem. If audience has any questions, we can go through. Do you have audience around? Hello? If we don't have audience around, we continue looking about it in a different way. As we mentioned, this is how we deal with the problem and how you look at any problem, including any medical problem. When it comes to nutrition aspects, we look at exactly the core of the problem. We don't look at the problem itself. Curing and medication can help, but we help in the core of the major problem. This is how we do our problem. Our part in nutrition is helping others to cure the major problem and in the same time lower the side effects, which goes for the inflammation that happen with the PCOS. As I mentioned before, some of the vitamins are really important. We add omega-3 to your food. You can take the omega-3 from foods such as fatty foods, or you can take it in supplementation. Especially magnesium and zinc are really important to add to the solving the problem. That was it, simply the how we deal with nutrition. The role of nutrition is not a minimal. Low of nutrition or role of nutrition is really important, that we add this and help to cure the case. Of course, nutrition has a major role, but we can prevent the case of happening, which is before you discover the problem. If we are in a good BMI, our body composition are good, we have a good athletic performance, we might help to prevent the whole problem. Thank you very much. That was all. If you have no questions, I'm done with that. And that's a very simple and brief how we deal with the problem. Dr. Muhammad?
Yes. Sorry, the mic was muted by the sponsor, the company, but now it is open. Go on.
Okay. I'm done. I explained the role of nutrition simply and what we can do about it and how can we help patients to lower their insulin levels and less inflammation according to the case.
Yes. There is one question. You can advise for a dietary advice for PCOS or PMOS?
Of course. We mentioned that in our explanation now, that this includes the
translated to the present food. This is a question of Doctora Sundus Musa. Yes.
The question is translated to?
Translate the scientific basis to a practical home food.
Yes.
Example.
Dr. Muhammad, I just mentioned that now, but I can repeat it again. We said that increasing protein is very important, and the protein level should be between 20 to 30 grams per kilo. Increasing fibers Adding snacks is very important. Lowering the glycemic index and helping people to shift from high glycemic index carbohydrates to lower glycemic index. And we said this can be oats, quinoa, sweet potato, and moderate fruits, fibers, and vegetables. And we give
The
an
same
example.
regimen for thin or obese women?
Of course, no. Of course, no. The weight of the patient, Dr. Muhammad, depends on the quantity on the food, not the quality of the food.
Yes.
Okay.
Very nice.
When we talk about thin women, we can increase the quantity of the food, but we cannot change the quality of the food because the patient of PCOS has two major problems. Insulin level, which is definitely high, even if she's thin. And I just mentioned that the majority of PCOS patients are overweight, even slightly overweight.
Yes, Dr. Mona Al-Houfi asking you about the glycemic index. What is the meaning?
The glycemic index is
Yes,
the
meaning of glycemic index.
in Arabic or in English? In English,
As you would like.
It's the factor that we measure all the food and its effect on insulin. This is called the glycemic index, the GI. Every food has a glycemic index factor. Like for example, the potatoes is a 55, the sweet potatoes is 45, the white rice is 65. So now we know that the white rice has a higher glycemic index than the sweet potato. You understand?
Yes.
Good morning.
Another colleague asking about the effect of intermittent fasting.
In general, Dr. Muhammad, IMF or intermittent fasting, or just fasting in general, the rule of fasting is that you stop eating or drinking or even fast on one type of food. If you stop eating protein, you're fasting on protein. But when it comes to the IMF and intermittent fasting, the major role of it is to fast between 12 hours up to 18 hours and maybe to increase it to 24 hours to get your body into the autophagy process. And if the audience don't know what is the autophagy process, it's the process that the body can convert or eat simply any different protein in the body or in the cell. This is the cleaning of the cell. The autophagy process is very, very important, and it starts after 12 hours of fasting. And here, when we talk about fasting, we talk about drinking, but not eating, and zero calories. So we talk about water and herbal drinks to get your body to this case. And when we go to this kind of autophagy process, we have a major problem that everybody has to pay attention to. The process of fasting, it starts the moment you stop the meal. After 4 hours from the meal, major 100%, 80% of people have a free stomach. Then your body starts to increase the insulin level to adapt or accumulate this food. After 8 hours, the insulin level starts to go less. After 12 hours, the insulin level is totally adapted. And here, when we start the fasting process, this can happen during the night or can happen during the day. When we reach 16 hours of not eating, your body starts to generate the energy directly from the lipids or the fat in your body. If we increase it to 24 hours, this is where your body intelligently works the autophagy process, where the body can use any extra or foreign tissue as a source of energy. And this is really important. And this is where we started the IMF, not as the practice that is happening now. The IMF definitely will lower the insulin levels, but will the patient be able to live their life fasting for 12 or 16 hours? This is very difficult. If Dr. Mona is asking about the practice, we usually encourage the patients to be normal in their lives And normal life will definitely need them to consume carbohydrates. That's why we mentioned to you, if the patient has only PCOS, she's not severe obesity, we work on it with the program that gives her 4 meals every day. And we depend on the 12 hours of fasting, which is the regular fasting of a normal human being.
Yes, many colleagues asking about the add-on drugs, especially myoinstol.
The question is, can we add the drug or no?
Add-on drugs as myoinstol. As you know, many companies all over the world are driving the use of myoinstol, proposing it is beneficial for PMOS patient. But the evidence is against that. In spite of that, many colleagues are still asking, what is your opinion?
My opinion, my friend, we still have the old cure medication, which is the diabetes medication that works, like glucophage 850 works perfectly. And in the other option as well, what we can do is to use the GLP-1. It gives a great results till now. But what you're asking about, I have no clear evidence that it helps.
Yes, very nice. And it go with the evidence.
Yes, but the GLP, to be honest, and semaglutide has a great effect on it. But still, we do have the major problem of it, which is the complication that happen in the stomach. So we have to be very, very careful, starting with the 0.25 injection, and we not increase to 0.50 until we check 100% the effect on the patient.
You would think, sir, the bypass surgery still have a role?
In my opinion, yes. In my opinion, yes. It helped. It helped some of the patients, but we have also to know and to be clear that the PCOS is a case that comes back again. It's not one-time cure. So many patients have been cured, then they have to suffer from it one more time.
Dr. Najla Yahya asking you about how can increase the muscle bulk.
Help? How increasing the muscle bulk will help in the case of PCOS?
No, with nutrition. This
Of
is
course.
a written question.
Back again, Dr. Muhammad, we mentioned that it's very important in the case of PCOS, similar to the cancer patient, that we have
Yes,
to increase
very nice
protein,
and the
that
clear
we
one.
have, yes, that we have to increase the protein levels.
Yes.
And the protein level will assure satiety and will assure the muscle level content, but not increased. To increase the muscle level, we need to add some exercises and weight resistance. Of course, we will do. And when this is going to happen, your BMR will be increased, your body will utilize insulin in a better way. So definitely adding exercise is important. But this gets us back to what I mentioned before, which is before the case is happening, we might have a role with a good nutrition of preventing the case or even delaying the process, or for the patient to know that she has a problem. We can delay this effect by changing the habits, by increasing the muscle mass, by improving the all over body function during the fitness level, and adding the proteins. It's very similar to the weakness with the cancer patient, that the patients cannot really utilize protein. That's why we said we have to start from 20 grams, increasing them to 30 grams per kilo.
Sorry to interrupt you. The source of protein, animal equal to plant, or
Okay, Dr. Muhammad, this is a great question. This is a great question, and we always talk about this with cancer patients. We know that we have 20 amino acids. It's the essential. 9 of them are essential. We cannot find them in the plant protein base except الفول الحراتي. I hope everybody knows what is this.
Yes,
Okay.
yes, in Egypt it's popular.
Yes, yes. Like, but the other plant proteins cannot really give the 9 essential amino acids. So yes, we need to differentiate or to distribute the 20 grams or the 30 grams per kilo among the plant protein and the animal protein, but at least 60% will be an animal protein.
Very clear answer. Any more question, my dear, my colleagues? You can go on if you still have.
What I want to clarify in the end, Dr. Muhammad, that nutrition has a major role in prevention, then it has a great role in helping patients to overcome the side effects, and also it has a great role in minimizing the side effects of medications. But please, for anybody listening to me, the main role of nutritionists, if we have nutritionists here among us, they have to think about the core reason, not to go through. For the PCOS, again, I have to repeat, the core reason is the insulin. The core reason will be the insulin problem. So we have to help patients to learn how to minimize the insulin and how to help the pancreas to utilize and use the insulin levels in a better way. This can go with increasing muscles, they can go with the nutrition program and learning to have more activity.
Yes, I think my last question, if you allow me.
Please.
What is about the vitamin D supplementation?
Yes.
And the Q10 add-on?
Of course, the Q-enzyme 10 is one of the major aspects, and we have to be very clear and where to get it and the concentration of it. It's very important. The Q-enzyme 10. This is a super question, Dr. Muhammad, and I have to thank you for it, because this is great for even cancer patients. The Q-enzyme 10 is very, very important. And the levels of vitamin D, unfortunately, when we look at the patients, the majority of them has a very low levels. And even if we have any patient now with us on the screen, she has to check vitamin D, she will be astonished to reach a level of 7. And this is a very low level. The majority, when they come to the clinic, when we check vitamin D, it's very low. Why? Simply why? Because people are talking about we live in countries that have the sun all over the year, but we're not actually utilizing vitamin D from the sun. And you have to know that the vitamin D is utilized in your stomach. If you have any minor problem in your stomach, so the utilization of vitamin D is very weak. So we have to check on vitamin D. We have to get vitamin D sources from food and from supplementation are very important. And as I mentioned before, omega-3, magnesium and zinc plays an important role in that.
We are grateful for your talk, and it is
Thank you, Dr. Muhammad. This is
very
great.
fruitful and double way talk, and this add on many beneficial to the audience and for me especially. And in behalf of American Association, we are grateful for your sharing, and we are looking for to attend the coming meeting in Egypt. I will be happy to meet you.
Pleasure, Dr. Muhammad, pleasure.
Yes. Any more question, my dears? Any more question?
No more questions, Dr. Muhammad. Thanks a lot, Dr.
Yes.
Thanks a lot, Dr. Muhammad. Thank you for the great talks.
Yes. The organizer can put their input for this nice about PCOS, and we are waiting for more items to be fruitfully discussed with an eminent professor from over the world. Thank you for all.